Hey guys, in this topic, I'm going to begin by describing some important scores with respect to the topic of liver. I'm going to talk about model for end-stage liver disease, then the pediatric version of it, Nazar's index, Madrid's discriminant score, and obviously what you are very comfortable with, even from your surgery classes, child-pug score. On this particular slide, I'm going to first tell you the utility or the reason why we do it, and then I'm going to tell you the parameters. And you will notice that when I'm going to describe you the parameters used to calculate the score, then two parameters will be repeated again and again. That's going to be bilirubin and INR, that is international normalized ratio. Now, the first reason why we are using a model for end-stage liver disease score is because it's a measurement or a metric which helps us calculate the 3-month mortality for any newly diagnosed case with end-stage liver disease. The minimum score possible here is 6, the maximum score possible is 40, and depending on how high or how low the score is, we can also prioritize who is the patient who's gonna get a liver transplantation. You see, once we have a brain dead donor and we are planning a liver transplantation, so we can prioritize the need, or we can prioritize the allocation of liver transplantation, and which is the body that will be deciding this. Then the international body that gives these algorithms or validates these algorithms is UNOS. UN would not here stand for United Nations, it would stand for United Network of Organ Sharing. Now I'll be telling you the parameters for MELD score as we progress subsequently in our discussion. In pediatric for end-stage liver disease, which is the pediatric version of the above score itself, you will have some additional parameters coming up, and most importantly, they would be growth parameters or nutritional status of the child. When it comes to child-pug score, it helps you determine two things. One, it helps you differentiate whether the patient is having compensated cirrhosis or whether the patient is having decompensated cirrhosis. And generally speaking, you as a doctor, when would you say that the patient is having decompensated cirrhosis? Then clinically speaking, apart from the MELD score value, one thing that tells you that the patient is decompensated is development of portal hypertension. Now, once the same patient of yours who previously was not having ascites has now developed a new onset ascites, and there's a splenomegaly, and there's a on endoscopy there are varices. They may not have bled because thanks to you, you were able to identify that there are varices present. You decided to start the patient on nadolol or on propranolol, which happens to be the drug of choice for non-bleeding varices. So you prevented a mortality with respect to life-threatening hematemesis. But as I said, clinically, how do you differentiate whether the person is having compensated or decompensated cirrhosis is presence or absence of portal hypertension. When I will be teaching you the classes of child-pug score on the subsequent slide, I'll talk like class A, class B, with scores of class B between 7 to 9. That once the scores are between 7 to 9, we'll say that the patient is decompensated. Anything less than 7, it would be compensated cirrhosis. And that helps me tell you the fact that when would you enlist a patient, like you have a patient of liver cirrhosis, when would you enlist a patient for orthoptic liver transplantation? Then you noticed me saying values like less than 7 or 7 to 9. So according to most of the books, enlistment for orthoptic liver transplantation should be done if the child-pug score of a patient is turning out to be at least 7 or more than 7. Similarly, I know you are going to put me up a question, sir, then what should we answer for MELD score? Then according to CMDT, current medical diagnosis and treatment, if MELD score of a patient is more than 17, then he should be enlisted for organ transplantation. Depending on the availability, he may or may not be given a liver. Nazar's index. I'll say like this, that the top 3 MELD, PELD, child-pug score you anyway know from your background knowledge, nothing great about it. But the last 2 parameters are the ones which deserve their respect with respect to the exam. That Nazar's index, where would you be using it and what's the significance of it? So your answer would be, I will use Nazar's index in patients of Wilson disease. Now, with respect to Wilson disease, well, one, it helps to determine the prognosis of this chap who is having hepatolenticular degeneration. This is autosomal recessive condition. Chromosome 13 is defective and ATP7B gene is defective. Standard information that you study in pathology as well. And in this patient of Wilson disease, my objective is to determine that should I be giving medical therapy to this patient. In medical therapy, I shall be giving zinc, and then even subsequently I might require copper chelators like trientine or dipencilamine, Or should I plan orthoptic liver transplantation in this patient of Wilson disease where excessive copper has damaged the liver irreversibly? Then the decision making for OLT versus medical therapy is again done on the basis of Nazar's index in patients of Wilson disease slash hepatolenticular degeneration. You will also notice a pattern. The moment I started talking about liver, I started talking about a chap with cirrhosis and need for liver transplantation. In all of these scores, we are always talking about cirrhosis, but one of these scores where I'm not going to talk about cirrhosis, but I'm going to talk about a chap with alcoholic hepatitis, not alcoholic cirrhosis, guys. Alcoholic hepatitis patient is Madrid's discriminant score, and this is mainly to guide treatment. And while I am writing this information, I would also like to put up a question before you here, that what is the drug of choice for management of alcoholic hepatitis? I know this is a recorded class, but I'm trying to give a semblance of a live one. Yes, guys, what is the best drug for management of alcoholic hepatitis? Because once there is alcoholic hepatitis, then the next step would be alcoholic cirrhosis. Then it will become decompensated. Portal hypertension will cause complications to occur, and then he can die because of bleeding varices, or there could be a very severe ascites, there could be hepatorenal syndrome, there could be hepatic encephalopathy occurring in a patient. So lots of complications to be discussed subsequently, but I would like to intervene right before he deteriorates towards that irreversible form of cirrhosis. Then I would like to use a drug that is prednisolone. Do not answer alcohol abstinence here. Do not answer acamprosate, naltrexone, disulfiram, and other related drugs. But your answer is we will be giving prednisolone or steroids for management of patients of alcoholic hepatitis. And what are the parameters in each one of these courses? What I'm going to tell you subsequently. But just have a quick revision here. MELD score is mainly is a metric to prioritize allocation for liver transplantation. Same for PET score. Same for even child pulse score. Nazar's index is for Wilson, and Madrid's discriminant score for alcoholic hepatitis. So I hope you're remembering this information. And now I'm going to focus on the parameters which are components. And you will also notice sometimes in lots of these online calculators available, when you put in the data for MELD score, it will also ask you for serum sodium values. MELD score will be having three parameters, that is bilirubin and international normalized ratio / prothrombin time. Normal is in a range of 11 to 16 seconds. The third parameter that comes up here is serum creatinine. And the query in the mind of most young doctors is that, sir, we are talking about liver, suddenly you're talking about a kidney parameter. Well, guys, lots of time you will notice that when the liver gets compromised, once you have a decompensated cirrhosis and you have a massive ascites in a patient, then subsequently even the kidney gets involved. You all are aware of a disease by the name of hepatorenal syndrome. So when the liver is decompensated, then subsequently kidney also gets involved, and if the kidney gets involved, creatinine values will spike, and that will worsen the prognosis of the patient. I can say it's like a double insult. Ammonia was already elevated, and now it's the creatinine values that are also spiking in the individual. And in any patient having hepatorenal syndrome, there is also going to be electrolyte derangement. So that is why even sodium values have been shown to improve the determination of the 3-month mortality. I'm not saying that MELD NA score is more accurate. Most of the time in hospitals, they'll be using a standard MELD score, but if MELD NA is given, then he says that you should give priority to MELD NA score for determining it as a metric for prioritizing allocation. But otherwise, as such, when it comes to the utility of both the scores, it is almost the same. Now, as I said, I mean, the scores mathematically will value, and more than 17 would be the critical threshold for which or beyond which you will enlist a patient for organ transplantation. So let me just write down the minimum score here, which is going to be 6, and maximum is going to be 40. And the next things that I'm going to tell you will rather get you more sensitized to why are we studying this topic. Suppose I have a patient who's identified with a MELD score of 20, and then there's a progressive deterioration of this patient, and he upgrades to, let me say, 25, goes up to 29. And then there's another patient of mine whose starting point was a MELD score of 30. And then it deteriorated before me over the next couple of weeks from 30 to 39. Then if I look at the mortality with respect to a score between 20 to 29, the mortality rate would be something in the range of 20%. I mean, I'll tell the family member that, well, your dad or your relative has 20% chances of dying in the next 3 months. Now let's look at what will you tell a patient who started off with a MELD at diagnosis at presentation. When he came to you first time, MELD score was, let me say, 30 or more than 30. you would tell the family member that your dad or your family member has more than 50% chances of dying. Like, you don't need to remember 19.6, 52.6. All you need to remember is that a person with a higher MELD score will have higher chances of dying. You can see a jump. You can see a jump here that's almost 2.5 times more higher chances of mortality. That's why I began by saying that this is a metric for 3-month mortality in a patient. And as far as MELD and MELD NA are concerned, no advantages of MELD NA over MELD, but if given in a question you have to choose, then first give MELD NA. When it comes to the PELD score, two parameters will be common: bilirubin and international normalized ratio. The additional parameter that you would be considering in this case would be one, serum albumin, because we are taking into consideration the nutritional status of the patient. Simultaneously, age will matter, and presence and absence of growth failure parameters will also be taken into consideration here. When it comes to Nazar's index, I'll fill up the data after a few minutes. Let me just utilize this time to first talk about child pug and discriminant score, mainly because they're again related or are relatively more frequently asked. Child pug score after bilirubin and INR, you just need to make an entry of 3 A's here. And the 3 A's that I think most of you are comfortable with would be serum albumin. And once the liver is compromised, I mean, liver produces albumin, albumin values will decrease. So it's going to contribute to development of ascites in the patient. And apart from this, as the liver will become smaller and smaller, ammonia will not be detoxified. Higher is the levels of ammonia, it can trigger a negative myoclonus. This negative myoclonus is called as asterixis, or is also called as flapping tremors. And once coma will occur, then the flapping tremors will also disappear in the patient. As far as discriminant score is concerned, the parameters incorporated are only two, that is bilirubin and INR. You don't need to remember any other parameters in discriminant score. And now we talk about Nazar's index. The two parameters, common ones, have been discussed. And now comes the third one, which should be remembered from the exam perspective. And because it is important, I'm just using a different color to mention it. That would be SGOT. So Nazar's index helps you decide whether you're going to go for a medical therapy or whether you're going to go for a decision for orthoptic liver transplantation in a chap with hepatolenticular degeneration. This is an important slide. The parameter parts are asked, and then the first slide was mainly for the understanding part, that why are we using it. Moving ahead in our discussion, the question that came in the previous year said, which happens to be which of the most accurate test for determining the severity of a person with chronic liver disease. Then the best way to determine the severity would be a real-time evidence. When I say real-time evidence, I can obtain that by doing a liver biopsy in the patient. What is the preferred site at which we can do a liver biopsy? The patient will be in a slightly head up, or I would say a semi-Fowler position. Head would be slightly elevated up to 30 degrees, and arm of the patient would be elevated as well, so that you can see the delineation of the anteraxillary line and the mid-axillary and the posterior axillary line. And the preferred site would be 7th or the 8th intercostal space. It would be mid-axillary line, and whenever you are doing an invasive procedure like this, it has to be by protocol ultrasound guided. And before doing this procedure, you must check the coagulogram of the patient, because all patients with liver damage are bound to have less levels of factor 7. You see, factor 7 has the shortest half-life. So the liver will be compromised, factor 7 values will rise. Therefore, prothrombin time will also rise. PT/INR is directly dependent on factor 7. And factor 7 has the shortest half-life, as I explained. So you must always try to get the PT back to normal. That would require sometimes even requirement of fresh frozen plasma, but you must ensure that the coagulogram reaches within the normal range before you poke in the needle. Otherwise, there could be life-threatening bleeding occurring in the patient as well. Now, what are you gonna determine on the basis of a liver biopsy? I mean, how is the pathologist gonna report to you this liver biopsy report? So you will notice two scores given. If you want to go into the details of these scores, then I would suggest you to listen to the main video. And at the moment, I will just focus on the names here. One of the scores on liver biopsy that the pathologist will give you is Metavir score, and the second one is called as Ishak score. With respect to Metavir score, the readings would be given, or the details would be given as F0 to F4. And with respect to Ishak score, the values would be given from a scale of 0 to 6, or the rating would be with respect to the severity of the disease. Now, our objective is not only to remember that we have a liver biopsy, which is understandably the most accurate test, but I would also like to rely on, like lots of time patients may not give consent for a liver biopsy. So I need to have some non-invasive tests also available to determine how bad the chronic liver disease is, and what are the steps that I should be taking. I mean, depending on less severe or more severe, I will be deciding or strategizing the treatment of this patient. Now, the non-invasive test that can tell me about cirrhosis is casually called as fibroscan. I mean, lots of time you will see physicians writing the word fibroscan. That's I mean, the word fibroscan in English helps you identify that you're trying to check out for the severity of fibrosis/cirrhosis in the liver. But technical word that I have to write for this would be called as TE, that is transient elastography. The concept is that you are going to send in a shear wave or an ultrasonic wave, and the speed with which the ultrasonic wave will travel in a normal ecotexture liver versus a fibrosed cirrhotic liver versus, I would say, a nodular cirrhosis liver would be different. So transient elastography is one of the methods, a non-invasive one also referred to as fibroscan. And another test would be called as fibro test. Now this would be having couple of blood parameters which we'll take into consideration. Bilirubin is one of them, obviously because liver is responsible for conversion of unconjugated and conjugated bilirubin. Then another parameter taken here would be GGT, that is gamma glutamyl transpeptidase. This is a marker that we use for identifying alcoholism, not alcoholic hepatitis. Alcoholism is gamma GGT, but alcoholic hepatitis would be SGOT. More about this as we progress. Let's look at few more parameters which are incorporated in the fibro test. One of them is haptoglobin levels. Traditionally, you read about haptoglobin with respect to intravascular and extravascular hemolysis, and in a pathology class we always study that the test that we use to differentiate intra versus extravascular hemolysis happens to be serum haptoglobin. But where is it produced? After all, it's produced in the liver. The next parameter that is taken into consideration here is apolipoprotein A. Whenever you read about lipid metabolism, lipoproteins always come in the picture. So apolipoprotein again is with respect to the functions of the liver. And another one is alpha-2 macroglobulin. So these are, I would say, blood tests by which you can identify the severity of cirrhosis in an individual. The third one is what you can relate more easily, that is a albumin globulin ratio. Now they love to ask that what will happen to albumin and globulin values in any chap with liver damage. So albumin values will be less and gamma globulin values would be increased. The question that I usually get from a lot of my students is, sir, albumin is less, understandable. Why is globulin elevated in liver disease? Then the reason why globulin is elevated in liver disease is because catabolism of this globulin component occurs in the liver. It is the breakdown, the catabolism that is in the liver is substantially reduced because the liver is damaged, and therefore if the breakdown will not occur, it's continuously being produced but the breakdown is not happening, so therefore the values would be relatively increased, and therefore albumin globulin ratio, as you can see mathematically, the ratio will decrease because numerator is lesser and denominator is increased. In fact, lots of time in the exam they can also give image based questions with respect to the same. So if you look at this image, what I have shown here is a normal electrophoresis report with respect to the serum. We will be having albumin, then we'll be having three types of globulins, that is alpha 1, alpha 2, beta, and then gamma globulin present. Obviously gamma globulin values will spike in multiple myeloma. You always read about M spike, but then there was a question in the exam in which he just gave this report, and the students of mine told that, sir, the albumin part which was shaded maybe blue in the exam, here it is red, the albumin part is lesser. And then if you look at it, the gamma part, the gamma globulin part is more. You can see the red curve is going above the baseline value which is shown, and the question said this is suggestive of. A lot of guys casually just thought or saw that what was happening was albumin was less, so they thought it is nephrotic syndrome, because in nephrotic syndrome again albumin is lost in the urine. But the point is, in nephrotic syndrome, apart from albumin becoming lesser, even globulin becomes lesser. In patients of nephrotic syndrome, you would be having urinary loss of globulin as well. The urinary loss of globulin will explain why nephrotic syndrome patients have infections, but the message is gamma globulin is lesser in patients on nephrotic. So if you get a question where both are reduced, albumin is also reduced, gamma globulin is also reduced, nephrotic is fine. But this particular, I would say, electrophoresis report which is present and is shown to you is that for cirrhosis, and nobody made a mistake for multiple myeloma. in this particular image, because that would have a very, I would say, peculiar spike, I mean a huge spike coming up like this with respect to the gamma globulin component, and that spike will also be relatively pointed. If you listen to the multiple myeloma component, that spike which is pointed is also called as a church spire appearance. Like the if you go to a church, right, the topmost part of the church would be relatively pointed, so the church spire appearance would be present. So I have explained on my previous slide with respect to chronic liver disease severity, liver biopsy, and then subsequently non-invasive tests that I can also be using. Next, I'll handle a couple of common questions which are asked here, which is the leading cause of cirrhosis. Pretty straightforward, alcoholic cirrhosis. But if he says what is the commonest cause of cirrhosis requiring a liver transplantation, then we would not like to waste our liver on a chap with alcoholic cirrhosis. I mean, if a person is alcoholic, he might go back to his days, or he might go back or relapse back to his original days of heavy drinking, and he might waste the precious liver that you've given him. So if he says which is the number one cause of cirrhosis requiring orthoptic liver transplantation, then an answer would be hepatitis C induced cirrhosis. In fact, the question was also asked another way. The question simply said, what is the number one cause of liver transplantation? And a lot of people casually answered alcoholic cirrhosis. As I said, I mean, we would not like to waste our liver on a chap with alcoholic cirrhosis. We need to ensure that there is abstinence documented in the patient by a psychiatrist, and that abstinence duration should be more than 1 year before we can say, okay, we will consider you for liver transplantation. Otherwise, I said, he'll waste the precious liver that you give him. I mean, it's going to be party time for him again, because one liver got destroyed, the doctor gave a new one to him. So the number one requirement for liver transplantation, or the candidates who would be given preference, would be hepatitis C induced cirrhosis. At this junction, I also want to tell you that hepatitis B is, I would say, the media makes it as a very dangerous virus, whereas in hepatitis B for Bombay, in 90% of cases, there is a recovery. Majority of cases of hepatitis B will recover. It is hepatitis C which is more dangerous. It causes a gradual destruction of the liver. It causes chronic hepatitis C, and then subsequently can cause hepatitis-induced cirrhosis as well. Now, the next question that comes up says, what is the most specific liver function test? Then your answer would be given as SGPT, but alcohol is metabolized in the mitochondria of the hepatocytes. And in the mitochondria of the hepatocytes, there is SGOT. I repeat once again, why did I say SGOT for alcoholic hepatitis? Is because where the alcohol is getting metabolized, and that's going to be mitochondria inside where SGOT happens to be present. And in a lot of questions, there is also possibility that he might write it in the form of a ratio. I mean, SGOT, SGPT ratio more than 1 signifies alcoholic hepatitis, and SGPT, if it is in the numerator, SGOT is in the denominator and the ratio rises, then it talks about the cytopathic effect, where let me say viral hepatitis could be one of the causes. The next question says, what is the best test for identifying any chap who's having obstructive jaundice? And obviously in obstructive jaundice, conjugated bilirubin values will be spiking, and the test, that the biomarker which will tell you that there is a damage is serum alkaline phosphatase, and you need to have at least a 4 times elevation. 4xr means a 4 times elevation of the value of serum alkaline phosphatase, so that you can say that this is having a cholestatic component. Now, they've also asked or correlated this with basic sciences, and they've said what is the site where serum alkaline phosphatase is located. Then the site that you will answer here is the bile canalicular membrane. This would be the excretory membrane with respect to the hepatocytes, where the conjugated bilirubin is excreted. So bile canalicular membrane of the hepatocytes is the site of serum alkaline phosphatase. And at this junction, I also want you to remember that we have a liver specific alkaline phosphatase, and then we have a bone specific alkaline phosphatase. Because when I'm going to talk about diseases like let me say hyperparathyroidism, then whenever PTH is more, bone turnover is more, so SAP is elevated. So the SAP that is elevated with respect to the bone is bone specific alkaline phosphatase. Here I've talked about liver specific alkaline phosphatase. Just to give importance or significance of this, bone specific serum alkaline phosphatase values would be grossly elevated in diseases whenever there is an increased bone turnover, like with respect to hyperparathyroidism. On the other hand, you will also read about bone diseases like multiple myeloma, but in them serum alkaline phosphatase is normal. Why? Because in Multiple myeloma, it is rather the plasma cells which are producing cytokines which are causing a damage. But I just thought it apt to mention here that bone specific serum alkaline phosphatase values are always normal with respect to two conditions. That is going to be a lady who's postmenopausal is having osteoporosis, and then is going to be multiple myeloma, and gross elevations can be seen anytime PTH values are increased. And even in cases of rickets, you could be having elevated values of serum alkaline phosphatase. With respect to these MCQs, I would say the most important one, which I usually find people getting wrong, is the second one, where I have shown that if a person is having the need for liver transplantation, I usually see people answering that as alcoholic cirrhosis. I mean, I agree alcoholic cirrhosis is common, but then for liver transplantation, the number one requirement would be mainly a hepatitis C induced cirrhosis. We will now focus on the common causes of cirrhosis in a patient. Why does it occur? And here some specific important information would be given to you, especially when I talk about autoimmune hepatitis. Autoimmune hepatitis, I want you to pay more attention than what you're paying right now. Standard is going to be alcoholic hepatitis, then it can progress to alcoholic cirrhosis, hepatitis B, C or D induced liver damage. At this moment, I also want to ask you here, I can just put up a simple question before you. I mean, what is the drug of choice for management of hepatitis B? If it is causing developmental liver damage and is causing chronic hepatitis, because in 90% cases recovery will occur. So there are two drugs which are available. One of them is tenofovir. Another drug that we use for management of hepatitis B is entecavir, and that's mainly for chronic hepatitis patients progressing towards liver cirrhosis. Similarly, subsequently, I'll be discussing drugs for hepatitis C and drug treatment for hepatitis D as well. If these two are not important causes of cirrhosis, then I can ask you regarding autoimmune hepatitis. And here, whichever antibodies I'll speak about, because it's of two varieties, autoimmune hepatitis type 1 and type 2, those ones I want you to listen to very carefully. Let me just enlist some other causes as well. Primary biliary cirrhosis, PBC. And then you will also read about primary sclerosing cholangitis. Here also they love to ask about antibodies. So I will speak about the names of them subsequently. Then could be a person who's obese and he's saying, sir, I'm having fatty liver. This chap is not an alcoholic, but he's having deranged lipid profile. He might be having metabolic syndrome, that is non-alcoholic steatotic hepatitis, that is NASH. People who can get developmental cirrhosis can also be due to metabolic reasons. That could be Wilson disease and even hemochromatosis. Hemochromatosis can be either primary or secondary. In primary, there is a HFE gene that is defective. In secondary hemochromatosis, it will mainly be packed RBC transfusion, which is the troublemaker. Then another cause which should be remembered is alpha-1 antitrypsin deficiency. You will always read about this with respect to patients who are having a pan-acinar emphysema. And then there are some special phenotypes related to it. So from the exam perspective, I want you to remember, in fact, I'll use a different color to highlight this, that people with alpha-1 antitrypsin deficiency does not mean that alpha-1 antitrypsin is not produced. It is being produced, but it is not being released or excreted out of the hepatocyte, so it keeps on accumulating inside the hepatocytes. There is a special ZZ phenotype present. You will read it as alpha-1 AT ZZ phenotype written. These are the patients in which alpha-1 antitrypsin is being produced but is not excreted out of the hepatocytes. So you will always see pathologists saying diastase resistant eosinophilic inclusions inside hepatocytes. So those pinkish eosinophilic inclusions inside the hepatocytes is alpha-1 antitrypsin, which was being produced but was not getting released, and therefore the accumulation of this results in damage to the liver and progresses to cause development of cirrhosis. And alpha-1 antitrypsin is also supposed to neutralize elastase. Elastase is produced by alveolar macrophages. If alpha-1 antitrypsin is not there to neutralize it, then there would also be a development of severe emphysema, which is called as pan-acinar emphysema. In fact, if you have a patient who's having COPD patients would be having pulmonary artery hypertension. Due to pulmonary artery hypertension, right ventricle will have to do more work. So there can be a right ventricular failure. If you have congestion in the right ventricle, it will also cause congestion in the inferior vena cava, because after all the blood goes to the right side of the heart via the inferior vena cava. And if you have congestion in the IVC, it will cause congestion in the liver, and congestion in the liver on long-term basis can cause CVC liver, chronic venous congestion of liver, and then subsequently a liver cirrhosis. A long story, right? I began by saying COPD. Then I said pulmonary artery, but let me just jot it down. I said, I have a patient of COPD. He is having subsequently a pulmonary artery hypertension. Due to this pulmonary artery hypertension, there's a lot of congestion in the IVC. There's congestion in the liver as well. We have chronic venous congestion of the liver. And then subsequently, there is also a cirrhosis component coming up. So because the heart was getting involved in, and then subsequently liver also got involved, so I'm going to use the word cardiac cirrhosis. One of these cardiac cirrhosis that you study in pathology, the terminology used is nutmeg liver. That's mainly to describe the congestion in the liver, because that would be reddish in color. And if we do not find any cause, if none of these causes have been determined, then we are going to call it cryptogenic cirrhosis, or the idiopathic variety of cirrhosis. And in earlier times, we used to use the term NCPF, that is non-cirrhotic portal fibrosis, but nowadays we use the word cryptogenic cirrhosis. Out of these 9 causes that I've written here before you, a large number of MCQs that you will get with respect to the topic of cirrhosis will usually try to test your ability to retain information with respect to autoimmune hepatitis. First of all, he will mix this up with histopathology. So 2 findings that you always get with respect to autoimmune hepatitis is one, interface hepatitis, and the second one is rosette formation. I mean, traditionally you read about rosette formation in pathology with respect to neuroblastoma or retinoblastoma, but here I am today describing rosette formation with respect to the liver, and we are not talking about any tumor which is having a UMA after retinate, I said, a retinoblastoma, or a neuroblastoma. It is rather autoimmune hepatitis being talked about. Now we will subdivide the discussion into 2, a type 1 and a type 2 autoimmune hepatitis, and it's the antibodies that is a must know for you. What I'm writing next before you is a must know information. That would be anti-SMA, that is anti-smooth muscle antibody. Another one is anti-SLA, that is soluble liver antigen antibody. The third one is again important, another ink change here just to highlight the significance of it. You have all read about P ANCA and C ANCA. No? You read about P ANCA is seen with microscopic polyangiitis, and then you read about C ANCA with vaginous granulomatosis / granulomatosis with vasculitis. But they asked about atypical P ANCA, and this atypical P ANCA is also written as X ANCA. You see, traditionally I said you read about P ANCA and C ANCA, but today I'm teaching you regarding X ANCA. ANCA is anti-neutrophilic cytoplasmic antibody. P ANCA is seen with microscopic polyangiitis. C ANCA with vaginous granulomatosis, but X ANCA / atypical P ANCA is seen with, the answer is type 1 autoimmune hepatitis. So why this is important is because in earlier times the term that was used, I'm going to write that term and then erase it. You will read, or when I was a student your age, I used to read this word leukoid hepatitis. Lupus, you understand, no? SLE manifestation. So leukoid hepatitis was a terminology. Even still today in books you will find this terminology written, leukoid hepatitis, because these patients are anti-nuclear antibody positive and they end up with development of jaundice, and then subsequently the liver scarring can even cause cirrhosis as a manifestation. Now let us compare this with type 2 autoimmune hepatitis, and let's see what are the antibodies which are to be remembered by you here. One of the antibodies, important one here, is anti-LKM, that is liver kidney microsomal 1 antibody. In fact, anti-LKM is again itself a gold mine of MCQs, but at the moment I said it is anti-LKM1 antibody for. The name is LKM1, but it is not for type 1 autoimmune hepatitis, it is for type 2 autoimmune hepatitis. These patients, anti-nuclear antibody will be negative. Rather, another antibody which would be present here is anti-liver cytosol antibody. So a gold mine of mines here from the examiner perspective, not a gold mine for you in a sense that you have to remember so much information. Let me just try to simplify things here before you. The minimum I expect you to remember is the name anti-LKM1 antibody is for type 2 autoimmune hepatitis. The second which I would like you to remember is X ANCA / atypical ANCA is related to type 1 autoimmune hepatitis. Now let us compare this with more antibodies coming up for primary biliary cirrhosis and primary sclerosing cholangitis. Primary biliary cirrhosis would be a pure intrahepatic problem. The cirrhosis will be with respect to the bile canaliculi, wherever the bile is present. In primary sclerosing cholangitis, the problem is mainly in the extrahepatic biliary pathways. It's outside the liver where the fibrosis will initially begin, and it's going to contribute to manifestations of stricture formation. Let me just try to draw this before you. Let me say this is the common hepatic duct from the left and the right biliary ducts. Then it would be united by cystic to form common bile duct, and this is where the bile is getting produced. So in primary sclerosing cholangitis, the problem will start from here. It would be primarily a extrahepatic process. As I'm saying, there would be fibrosis in the bile ducts occurring initially, and then the progression of the disease will also cause fibrosis around the area. Red can be taken as representation of where the bile is being produced, bile canaliculi. So subsequently, the green here is showing the fibrosis that can be occurring even around the bile canaliculi. The importance of knowing this is that if the number of these strictures is lesser, or I would say in the distal part of the biliary pathway, we can still try stenting of the biliary pathway to relieve the jaundice of this patient. But once the disease process becomes intrahepatic, then it will become relatively irreversible. Now, in primary biliary cirrhosis, the antibody which is to be remembered by you, again important from the exam perspective, so just be patient while I jot it down. The antibody to be remembered is anti-mitochondrial antibody. It is anti-AMA antibody, and while I'm writing it, I hope I can raise a red alert here by saying do not mix it with anti-microsomal. I mean, you are obviously not going to mix up AMA, M for Mauritius versus ANA, that is N for Netherlands. I mean, AMA, ANA, you will not have a problem. You all guys are brilliant chaps. But anti-mitochondrial and anti-microsomal antibody, there are issues which I find people not able to retain. Question for you guys here: anti-microsomal antibodies are seen with? Yes, guys. I described that in the endocrine topic. That would be with patients who would be having Hashimoto's thyroiditis. When you read about autoimmune thyroiditis, that's where you read about anti-microsomal. This one is anti-mitochondrial antibody. For primary sclerosing cholangitis, it's gonna be P-ANCA. So earlier I spoke about P-ANCA related to polyarteritis nodosa, but then I am talking about primary sclerosing cholangitis being also associated with P-ANCA. And you will also see me talking about P-ANCA even in inflammatory bowel disease, because in patients of IBD, especially ulcerative colitis patients, can be having primary sclerosing cholangitis and therefore P-ANCA positivity. So P-ANCA has been discussed for polyarteritis nodosa, and mainly the version of it, that is microscopic polyangiitis. Then is going to be primary sclerosing cholangitis and inflammatory bowel disease. Now, anti-LKM1 antibody that I described to you can be having subtypes as well as LKM1, 2, and 3. With respect to anti-LKM1 antibody, I've already explained to you that it can be seen with autoimmune hepatitis. The subtype was type 2. And I also want you to remember this can be associated with hepatitis C as well. In contrast, anti-LKM3 antibody is associated with hepatitis D, and the most important one of them that they love to ask is anti-LKM2 antibody. Your answer for this would be given as drug-induced hepatitis. These are some fact-based information that should be remembered for liver-kidney microsomal antibody. And next, I'll be explaining to you regarding what happens when a patient has decompensated cirrhosis. He's going to end up with development of portal hypertension. Once it ensues, then there could also be development of bleeding esophageal varices. Prior to that would be non-bleeding varices in a patient. So when would I be saying that there is a portal hypertension in the patient? I mean, the pressure more than how much? Then the technical definition that you will answer will be that if the hepatic venous pressure gradient is more than 5 millimeter of mercury, that is when portal hypertension has started. And when would you be having esophageal varices developing? You see, initially they would be non-bleeding, and then subsequently they will become bleeding. So I have just symbolically shown here is the esophagus, and then I've also shown some veins which are not only congested but they are collapsing into the lumen of the esophagus. Then if the pressure would be in excess of 12 millimeter of mercury, that is when esophageal varices will occur. You would be expected to start the patient either on nadolol or on propranolol, and this way you will reduce the chances of conversion of non-bleeding varices into bleeding varices. For bleeding varices, obviously the drug of choice is octreotide, but for non-bleeding varices you would be using a beta blocker, either nadolol or propranolol, whichever is available in the patient. The pressure values that I explained to you for esophageal varices was in excess of 12 millimeters of mercury. Now let's see what happens subsequently. As the pressure in the portal vein will rise, why? Because there is a progressive fibrosis occurring in the liver. The hepatic stellate cells are working. Over time, you very well know stellate cells are the ones which contribute to fibrosis. So the congestion will be translated to or transmitted to the splenic vein, and therefore the spleen of the patient will become enlarged. Therefore, one of the early as well as a reliable, I said two things, early as well as a reliable examination finding that you get in patients of portal hypertension is splenomegaly. Subsequently, you will also have development of ascites. Though ascites can be picked up early on the basis of puddle sign, but routinely in your OPD, you don't check out for puddle sign. Lots of time patients may not be able to realize that they are having a substantial abdominal distension. He might just think that it is belly fat or centripetal obesity, which is contributing to his stomach girth, abdominal girth increasing. So when it comes to ascites in a patient, there are two possibilities. Either the patient may fail to recognize that there is a problem, and even if he fails to recognize, lots of times the doctor might even fail to recognize the presence of ascites, maybe because the person was obese and there was a pre-existing centripetal obesity present in a person. But when it comes to splenomegaly, it is relatively less missed because we try to check it out. On a comparison basis, I just want to sensitize you to the fact that splenomegaly is a reliable examination finding over and above ascites, which could be, misdiagnosed, and you could even have a false positive diagnosis of ascites as well because of the obesity component, or vice versa. A very fat person, you might even miss it as well. In the same patient, because the mesenteric veins would be involved, so no big deal, the pressure will be transmitted even to the hemorrhoidal veins, and therefore rectal hemorrhoids could be a manifestation, or lower GI bleeding could also be a manifestation occurring in the person. Now, what test would you help you pick up whether the person is having portal hypertension? Then your answer would be given as Doppler. Doppler would be the best way to pick up the increase in the pressure. A Doppler ultrasound is the best investigation to help you, and it's a non-invasive investigation, so it would help you identify that the pressure in the portal vein is increased. Let's look at what other findings would you be finding in the patient, and I'm trying to mainly guide you towards caput medusae, which would be found around the umbilicus of the patient. And how would he ask about this is with respect to the location of the portosystemic collaterals, because as the pressure in the portal veins will rise, then the body will try to decompress the system by forming collateral circulation. So one that will be formed is esophageal veins becoming prominent, that is esophageal varices. This is one of the weakest link in the circuit. They'll rupture and then the all mayhem can break loose because patient will be having hematemesis. For rectal hemorrhoids, I've already spoken about. Lower GI bleed manifestation could be occurring in the person, and any bleeding in a liver disease patient will be difficult to control because the coagulogram would anyway be deranged. He can say what are the sites where you have portosystemic collaterals. So the two sites that I mentioned will cause manifestations and will show up. Both esophageal varices and rectal hemorrhoids are, I would say, showing up clinically. But with respect to bare area of the liver, it's only from the anatomical perspective that you would be having portosystemic collaterals, but you obviously can't see it in the patient with your naked eye. Then is caput medusae. Now for caput medusae, around the umbilicus of the patient, there would be these dilated veins which would literally look like snakes. And he can also ask about the flow of blood which would be in these veins. That is it gonna be flow of blood towards the umbilicus or away from the umbilicus? So the flow of blood that occurs is always away from the umbilicus of the patient. This is in contrast to, now listen to my next information carefully. Suppose they give an image-based question in which you are able to visualize the umbilicus of the patient, and you're also able to see these dilated veins which are present above the umbilicus, and by arrow he also shows flow. You can see that obviously in an image-based question, because you're not anyway palpating and it's not a 3D image, so you may not be able to pick up which way the flow is. You need to touch the patient to evaluate how the flow is. You need to milk the veins and then check out the flow. He'll give you arrow to describe the flow. You can see that I've shown the veins only above the umbilicus, and the flow is towards and not away. Then this is definitely not caput medusae. This would be a feature that would be seen with superior vena cava thrombosis, and therefore the collaterals are being formed. Similarly, let me just draw it, that suppose this is umbilicus of the patient and you get an image-based question in which the veins are present inferior to the umbilicus and the flow is towards the umbilicus once again, then this would be a case of inferior vena cava thrombosis. I'm not written it because it's obvious. I want you to be sensitized to an image-based question that in caput medusae, the veins are gonna be circumferential. They're gonna be present 360 degree around the umbilicus of the patient, and the flow will be given in the form of an arrow because you can't milk the vein obviously in by looking at an image, and this would help you pick up this is caput medusae. I'm sure you're not gonna mix it up with the spider angiomas, because spider angioma is what you see with cirrhosis. One of the manifestations, a cutaneous manifestation that you always see with cirrhosis of the liver is spider angiomas. And where would you check for spider angiomas? I mean, spider angiomas are arterioles. These arterioles will mainly be seen around the superior vena cava distribution. So you'll have to ask the patient to remove his shirt or t-shirt, and you see it over the shoulders of the patient and neck area. Spider nevi is seen in superior vena cava distribution. It is one of the features that you would encounter in patients with cirrhosis. But then spider nevi or spider angioma can be seen in pregnancy also. It can be seen in rheumatoid arthritis also. So, I mean, do not be under impression that spider nevi is a very reliable feature for identification of cirrhosis. I said it can be seen in pregnancy, it can be seen with rheumatoid arthritis, and obviously with cirrhosis, which is the topic that we are studying. And then spider nevi slash angiomas would be arterioles, which would be radiating from the center. These peripheries would look like limbs of a spider. It is SVC distribution where it would be seen. These are arterioles, whereas in caput medusae, it is the veins that I have shown before you. Apart from this, there would also be another site of portosystemic collateral, that is omental veins. Then is retroperitoneal veins and lumbar veins. Point number 3, 5, and 6 that I have described before you, 3, 5, 6, 7 that I have described before you, they are basically satisfying, I would say, the anatomy, the wish of the examiner that you are good with anatomical component as well. From a clinician's perspective, when it always comes to portosystemic collateral circulation that develops in patients of liver cirrhosis, from a clinician's perspective, it would always be point number 1, 2, and then 4, which would be of primary concern to me. I mean, this would tell me that my patient is deteriorating. Otherwise, it is total of 7 sites of portosystemic collaterals where the anatomical aspects have also been incorporated. Point number 3, 5, 6, 7 obviously cannot be seen by you, but all of these findings tell you, especially 1, 2, and 4, tell you that your patient is deteriorating. And GI bleeding is always I would say, a disaster in any patient of liver disease, because when there is internal GI bleeding, then there could be, because there's a deranged coagulogram also. So if there's going to be internal GI bleeding in any patient of liver disease, then it will promote the growth of bacteria, because blood is a good culture medium. So if you promote the growth of bacteria are the source of ammonia production. So the ammonia levels will spike, and therefore they can be a triggering of hepatic encephalopathy. So you will usually see this word written in the textbook that internal GI bleeding triggers hepatic encephalopathy. How that happens, I explained to you. The internal bleeding, one because of deranged coagulogram in a patient, plus all these aspects, esophageal varices, if it's occurring, obviously he will vomit blood, but some blood due to gravity will go down also. No? It will go via the stomach into the small, into the large intestine. So it will be acted upon by the bacteria. The bacteria will proliferate in the presence of blood, because blood is an excellent culture media. And the most common, I would say, the major site of ammonia production in the body is the intestinal bacteria. The most common site of ammonia production in the body, ammonia is detoxified in the liver, but it is produced by the gut bacteria. So if the bacteria will get more blood, then they'll multiply more, produce more ammonia, and hepatic encephalopathy could be a complication that could be developing again in patient of portal hypertension. As I told you, portal hypertension is all about decompensation. How did it start? It started with a splenomegaly. Then the patient progressed to development of ascites, also had bleeding occurring, either in the form of esophageal varices or hemorrhoids, or both of them. Plus there is a coagulopathy. So you can see so many problems occurring in the same patient that it's a little difficult to manage these patients, which is why we have is a lower threshold. I mean, when it comes to child per classification, usually in class B itself, we plan or we schedule a patient. It's not that you're going to do it, but you enlist a patient for OLT, that is orthopic liver transplantation. Therefore, the learning from the previous slide is that every time you get a question of hematemesis and there is also a splenomegaly described in the question, then it's not going to be peptic ulcer disease. Agreed that if the question simply says what is the most common cause for development of hematemesis in a patient, answer is peptic ulcer disease. But if it's going to be splenomegaly described in the question as well on a per abdominal examination, then you must think in terms of portal hypertension. He may not begin the question always by saying alcoholic patient with cirrhosis, presents with upper GI bleeding, and then what is your diagnosis? Because if he's saying alcoholic cirrhosis, you know you can answer portal hypertension and bleeding varices. So he will just say a patient presented first time in the casualty with the upper GI bleed, and then on per abdominal examination you found a splenomegaly. So that's where you will answer it as portal hypertension. And portal hypertension can be artificially classified into prehepatic, hepatic, and posthepatic causes. So I'll first focus in the middle of the table, where I'll be describing three subtypes of the hepatic variety, which is called as sinusoidal, pre and post sinusoidal, because extreme left and extreme right is easy to comprehend. Whenever you read about sinusoidal variety of hepatic cirrhosis, portal hypertension, it implies that the patient is having liver cirrhosis. But if it says pre-sinusoidal, it's intrahepatic, it's inside the liver, that's okay, but it is pre-sinusoidal, before the sinusoids of the liver, then this could be a worm infestation. One of the important ones to be remembered is schistosomiasis. So we do read about schistosomiasis, also responsible for hematuria, but or even eosinophiluria, eosinophils in the urine. But today I'm talking about it with respect to the pre-sinusoidal variety of portal hypertension. And when we have post-sinusoidal variety, then don't answer Budd-Chiari. Budd-Chiari would be answered by you as a post-hepatic cause. Post-sinusoidal can be one remembered for radiation. This was therapeutic radiation. Maybe patient had Hodgkin's lymphoma and abdominal lymphadenopathy was present, for which radiation was given. Or it could be herbal teas. Lots of these herbal teas or green teas which are marketed may not be actually good for health, in a sense that they can cause damage to the liver. And then in PSM, you read this term endemic ascites. You always read in PSM in food adulterant topic pyrrolizidone alkaloids. Those pyrrolizidone alkaloids, they contribute to endemic ascites, and this is going to be the post sinusoidal variety of portal hypertension occurring in a patient. Now, when it comes to the extreme right hand side, that's relatively easy. Post hepatic means that it is either the hepatic vein. I mean, post-hepatic, don't straight away think that it's going to be IVC. Hepatic vein and extension into IVC is Budd-Chiari syndrome. Then if a person is having inferior vena cava thrombosis, even then the outflow from the liver is getting hampered. And if a person is having cardiac cirrhosis, as I described a case to you, COPD patient, pulmonary artery hypertension, then right ventricle getting involved, and then there's congestion in the IVC of the patient, that would be nutmeg liver in pathology, is referred as cardiac cirrhosis and is a post-hepatic cause. For pre-hepatic, it will never be a problem for you. Portal vein thrombosis. One of the causes for portal vein thrombosis can be, especially from pediatric perspective, I can recall in 2020, which was the lockdown time, there was a FMG exam in which they had given a clinical scenario, very difficult MCQ actually. The question said that the child had undergone an umbilical artery catheterization, and during this umbilical catheterization, there can be a development of subsequently to umbilical artery catheterization in the child, there can be a portal vein thrombosis. I mean, the question said that the child in his neonatal age had undergone a development of umbilical artery catheterization. And then the same child after 6 months started having features suggestive of portal hypertension. There was a splenomegaly, ascites occurring in a patient. The question said, what is the reason behind it? So instrumentation at the time of birth, that is, by instrumentation I mean a pediatrician did a catheterization of the umbilical artery, maybe for exchange transfusion of the child. And that resulted in, because you're putting a catheter right up to the where the portal vein would be starting. So that can trigger a portal vein thrombosis and later on can cause a development of portal hypertension in the patient. Similarly, even splenic vein thrombosis would classify as a prehepatic cause. The third one that I am saying before you is relatively rare, but why is it important is from the perspective that one, you will read about what is called as Bantu syndrome, another that you will read is called as Bunty syndrome. So let me just explain Bunty syndrome for portal hypertension, which is an idiopathic variety, and this is not to be mixed up with Bantu syndrome. Now, Bantu syndrome is mainly found in Africans, and this would be iron related damage to the liver. Like in India, they store sometimes water in copper utensils or brass utensils, which I can say in Hindi is pital ke bartan. That pital ke bartan is brass utensil. So brass is an alloy of copper, and if water is stored in that alloy of copper, then you could be having copper toxicity, that is called as Indian childhood cirrhosis. Similarly, in Africa, the locally brewed beer is kept in iron utensils, and this iron utensils can contribute to iron related damage to the liver, which is called as Bantu's disease. So Bunty was a idiopathic one, but Bantu is gonna be a totally different disease. I mean, Bunty versus Bantu is what I wanted to remember. Bunty, I coming up idiopathic. Bantu is iron utensils and iron toxicity that contributes to development of liver. Bantu is not a part of this classification, in a sense that the Bantu has been described mainly to tell you from the etiology perspective. Otherwise, I have talked about causes of portal hypertension occurring in a patient, and once this portal hypertension ensues, then our patient could be going and progressing towards first non-bleeding varices and then bleeding varices. The drug of choice for management of non-bleeding esophageal varices, the first answer of yours can be given as a beta blocker, that is nadolol. Otherwise, it is propranolol. Propranolol will also be studied by you in cardiology with, in fact, I can just jot it down. I mean, propranolol was discussed as the drug of choice for hypertrophic cardiomyopathy. It was also told to you in neurology as for prophylaxis of migraine. And then we will also be using it in patients of thyrotoxicosis to mitigate the sympathomimetic stimulation that would be occurring in the patient. And one of the fourth uses is the topic that is on the agenda at the moment, that is non-bleeding esophageal varices. But unfortunately, if the person develops bleeding varices, and he also mentions that the BP of the patient is reduced, there is a hemodynamic instability in the patient, he will describe that this alcoholic patient is having a splenomegaly, but then because the vital parameters of the patient would be given and the BP of the patient is given to be low, let me say 80 by 60 or 90, he will give you outrageously low values. So your objective would be to first stabilize the patient, and you will have to put in a cannula in the patient. So yes, I want to give a massive blood transfusion in case there is a substantial blood loss and the patient has gone into shock, but it may not be available initially. So I am securing a gray cannula in the patient. I've set the sample to the laboratory for blood grouping and cross matching, and I will initially be starting IV fluids in this patient by the time I'm able to obtain blood. If, let me say, he's giving you unrecordable blood pressure, suppose he gives you a scenario of decompensated shock. For compensated shock, we use ringer lactate, but if it is decompensated shock, you would be using normal saline in the patient. Anytime it is unrecordable blood pressure, always answer normal saline. If it is recordable blood pressure, compensated shock, I mean, difference between compensated and decompensated is blood pressure is unrecordable. If he says crashing patient, then for crashing patient, IV fluid I'll start is normal saline, and ultimately in the next couple of minutes, I hope that my blood bank would be able to support me and provide blood transfusion to this patient. So if he says what is the initial management, it is volume resuscitation. If he says which is the preferred method of volume resuscitation, then the preferred method of volume resuscitation is blood transfusion. But why did I write normal saline initially? Because when patient will come right now, you don't have blood available immediately. It will take you to fill up a requisition form, take up a blood sample of the patient, send it to the laboratory. So there have to be some administrative, I would say, turnaround time that has to be incorporated. But the best way to manage this guy is provide a blood transfusion. Then we will also be giving octreotide to this patient. Instead of octreotide, in some books even terlipressin can be mentioned. Not too much of differences. I mean, octreotide would be given in the form of an infusion to the patient. And then once the bleed has reduced, I'm not saying totally stopped, it's reduced to a ooze and the BP is gradually picking up, then we will do a upper J endoscopy and go in for endoscopic variceal ligation. EVL would stand for endoscopic variceal ligation or sclerotherapy. I mean, depending on the skill of the operator, that is a super specialist, a gastroenterologist would be taking up the case here from you and then do either an endoscopic varicose ligation or going in for sclerotherapy. In most of the cases, in case you're going to manage the patient in this fashion, there is going to be stoppage of bleeding and the patient will recover. However, in some cases, there is also a possibility that he might ask you regarding a person having recurrent bleeding from esophageal varices. Like maybe AVL was done once, but on whichever side AVL was done, endoscopic varicose ligation was done. Now the veins which are superior to that area might actually start bleeding. So if he says person is having recurrent bleeding from esophageal varices, and what is the first step of the patient? So assuming that the hemodynamic stability of the patient has been taken care by the physician right on admission, I would like to repeat the endoscopic varicose ligation so that whichever veins that were not ligated initially will be taken care of now. Now there can be two possibilities with respect to the patient. There is a control of bleeding that has occurred. I mean, I did this activity and there is a control of bleed that is occurring, but the subsequent management will depend upon the child pug score of the patient. Like suppose he is child pug classification, that is class A. In child pug classification, when I say that the patient is class A, this means the score of the patient will be something in the range of about 5 to 6. I told you about the parameters present, that is bilirubin, it was INR, albumin, ascites, and asterixis. So if it is child pug classification A, then we would be preferring a TIPS procedure to be done in these patients. But in case we find that he has decompensated, if the score of the patient is more than 7, it means that he has decompensated. In these patients, we should directly try and go in for transplantation evaluation. The objective of telling you this was that once you have controlled the bleed, you need to take care of the fact that if the pressure in the portal vein is, and you see what is happening here is endoscopic varicose ligation is like shooting the messenger. See, where is the problem? Problem is not in the esophagus. Now, problem is not in the esophageal veins. Where is the pressure increase in the portal veins? So when I say shooting the messenger, it is that the poor esophagus which is suffering, you are trying to control the bleeding from there, whereas the actual problem is setting in the portal vein. You need to decompress it. So whether you will decompress it with help of tips or would you straight away plan a liver transplantation in a patient will depend upon a child pug score in the patient. And this again gave me, I would say, an opportunity to tell you the importance of child pug score, that it helps you decide what course of action should be done in the patient. And suppose I'm saying you are not able to control the bleeding in spite of doing a repeat EVL. Let's consider a worst case scenario. This I don't want you to note down. I just doing this discussion for an academic purpose. Suppose you have done endoscopic varicose ligation twice and still bleeding is occurring. And you are wondering, man, what's going on? The endoscopic is wondering, man, what is going on? I have done everything. I mean, whatever veins were visible, he's done the ligation part or the sclerotherapy component. He's wondering, sir, where is the blood coming from? The blood could be coming from the stomach. The guy puked again. It was blood. The blood this time is not coming from the esophagus because you took care, the endoscopist took good care of all the esophageal veins that were liable to bleed. So the blood could be coming from the stomach because after all, if the pressure in the portal vein is more, then the pressure in the gastric veins will also be more. And this increase in the pressure of the gastric veins can cause continuous oozing of blood into the stomach and can irritate the stomach lining, and therefore the person could be having bleeding. So the term that we use here is called as portal gastropathy. In portal gastropathy, when you do an endoscopy, you would be having a mosaic appearance of blood vessels with respect to the stomach wall. I mean, the endoscopist will be able to pick this up. This is one of less common presentations, but this can happen that the person is still turning anemic. I mean, it will not be always that he is puking blood. It is a progressive anemia. You have done endoscopic varicose ligation in a person who's having bleeding, who had bleeding varices, maybe 2 episodes and 2 times varicose ligation was done. But in spite of that, though he did not develop a bleed for the third time, lots of time I'm saying he might bleed for the third time and you're wondering where the blood coming from. Blood is coming from stomach. Another possibility can be that he may not have bled. I mean, visible bleeding may not be present, but still because he is losing blood by the stomach and therefore any blood loss from the body will contribute to anemia. So progressive anemia in spite of endoscopic varicose ligation. can again be a pointer towards diagnosis of portal gastropathy. I'll repeat the facts once again, guys. What I'm trying to say here is that a chap had endoscopic varicose ligation for bleeding varices done. He bled again, you again did the procedure. Even then there is bleeding present, even after this. Then you must consider the possibility of portal gastropathy. And by bleeding, I don't mean that he may have bled or puked blood the third time. It is just that when you did a follow-up of this patient after 3 months, you found that there is a substantial decrease in the hemoglobin values, and you ask the family member, maybe they took him somewhere else, no, lots of time they may not have brought him to your hospital, and you ask the family member that did he bleed again, and they said no, no sir, he has been okay, but he's been turning pale. So in patients of portal gastropathy, again there is a need for going in for tips in the patient. This is one more indication for performing a transjugular intrahepatic portosystemic shunting. One is a person who is having recurrent bleeding, decompress the portal vein, don't shoot the messenger, treat the cause. Second is portal gastropathy. Then subsequently, in this particular slide, I want to draw your attention to the fact that if in the question he mentions this hemodynamic instability, then always first focus on reviving the hemodynamic status of the patient back to normal. Ensure that the kidneys are working fine. Ensure that the urine output of the patient is as close to 1 ml per kg per hour. And once we are able to achieve a good volume status in the patient, then subsequent steps are to be answered. The next topic that I'm going to teach you is ascites. And the first and the foremost thing that we'll study is how much fluid should be present in the peritoneal cavity minimum so that it can be picked up by puddle sign. Now, in reality, you see, we don't do a puddle sign regularly. Though you can pick up fluid present in the peritoneal cavity, even if it is less than 100 ml by ultrasound, but clinically speaking, puddle sign would pick up more than 100 ml. And you would need a very high index of suspicion for ascites to be present to actually do puddle sign in your outpatient department. Most of the time, we might miss ascites initially. Now, as the amount of fluid will increase, and this that I'm putting is a fluid amount that will vary on the size of an individual. If it's a very tall person, you may not be getting a shifting dullness initially. But let me say for an average size Indian patient, most of the time when the fluid amount will exceed 500 ml, that is when shifting dullness can be elicited. Subsequent to this, another clinical sign that will come up is called as fluid wave sign. However, when you read the literature of this fluid wave sign, you will also notice that this can be false positive. And who are the patients where they would be false positive? If the patient is having a pendulous abdomen, lots of time you might be having a grand multipara who might be having a pendulous abdomen, due to which the fluid wave sign might turn out to be false positive. Or I can say that even if you're not seeing, grand multipara patients regularly, because you would lots of time not be sitting in the OBG department, then obesity patients, centripetal obesity due to metabolic syndrome, again, this can be false positive. Subsequently, you will also notice that the superficial veins of the anterior abdominal wall will become prominent. And not only the superficial veins of the anterior abdominal wall, if you see caput medusae will still take some time to develop, but the superficial veins will become grossly dilated that you will be tempted to put a cannula in them, but they'll be having a very tortuous course. And in the later stages, it will just look as if the vein is so distended that it will pop off at any point of time. You will also notice that the patient might start having a everted umbilicus, and at this point of time the amount of fluid will be substantial to the level that even person can be having respiratory distress. Lots of time in these patients, when you might do ultrasound chest, or if you are going to do a x-ray for example, you might even notice blunting of the cost of running angles. Now the question arises, patient is having ascites, then why is there a blunting of the cost of running angles in the patient? Well, the ascitic fluid can actually migrate via the diaphragm. There would be holes in the diaphragm, if I can put it unofficially, by which the ascitic fluid can migrate to the chest cavity. And this is the reason why in the textbook, whenever you read about ascites, you might always read that the patient is having a hepatic hydrothorax. Well, I can give two reasons for this hydrothorax. One, I said the fluid can migrate right via the diaphragm. The second is that anytime there is going to be a liver damage in a patient, the albumin concentration is less, and this affects the oncotic pressure. And you very well know that if the transudative, when you read about transudative pleural effusions, that is when you read either the hydrostatic pressure is more or oncotic pressure is less. So here I'm saying that albumin is less, oncotic pressure is less. So again, the pleural effusion part can be explained. The reason why we are worried about a patient of ascites is because there is a possibility of development of abdominal compartment syndrome. Now you are there to obviously prevent this from happening. You will do a early identification of ascites, but if suppose a patient does not seek advice, or let me say in COVID times, what happened was when the Delta strain was peaking in our country, at that point of time due to COVID in 2021, all hospitals began COVID hospitals and regular care of patients was hampered. I mean, all patients, all wards were converted into COVID wards. So a lot of these patients never got admitted. And this could have resulted and did happen actually in a couple of patients that the ascitic fluid became so gross, alcoholic cirrhosis patient, a massive ascites, that the patient started developing abdominal compartment syndrome, which can even cause gangrene of the intestine. They've asked in the exam intra-abdominal hypertension topic and then abdominal compartment syndrome. Do you read that in surgery as well? For intra-abdominal hypertension, the pressure should be more than 12 millimeter of mercury. Abdominal compartment, there are grades actually. And abdominal compartment syndrome starts manifesting when the pressure goes more than 25 millimeters of mercury. And here what's happening is that the mesenteric veins are getting kinked, due to which the gut flow is hampered, and that explains the gangrene that could be occurring. At this point of time, I would also like to mention that if the question says what is the minimum amount of fluid that can be clinically detected. Now, when I describe the amount here, minimum amount clinically detected, you will argue that, sir, on one hand, you were saying 100 ml is the minimum that can be detected by puddle sign. But I also told you that in regular OPD or in regular practice, hardly you will see a doctor doing a puddle sign. Most of the time, we are hardly doing puddle sign. And most patients in India anyway come to us late. So therefore, what both Harrison as well as Hutchinson says, that the minimum amount to be clinically detectable. You see, for the first point that I was saying, puddle sign one, if you are not skilled and you've not done a puddle sign earlier, you may not follow the steps properly and you might miss the amount. And secondly, if the patient comes late anyway, I mean, you would not be able to identify. So what I'm saying is, due to delayed presentation of patients, clinical detection usually occurs when the amount of fluid is as much as 1.5 to 2 liters present in the peritoneal cavity. And due to high incidence of centripetal obesity in our country nowadays, because of especially urban India, due to metabolic syndrome coming up, there is again a possibility that you might think that the person is having a centripetal obesity component, and the ascites component can be missed also. Once you identified this, subsequently in this patient of cirrhosis, you would start treatment of the patient. First and the foremost would be a salt restricted diet, because ascites is a condition where there would be a hyperaldosteronism state. You see, ultimately there is wastage of fluid in the peritoneal cavity. This fluid should be in blood vessels, but it is redistributed in the peritoneal cavity. So circulating fluid volume is hampered. This affects the RAS system. The positive stimulus from the RAS will cause hyperaldosteronism, so salt restricted diet. And then we shall be using diuretics. Now, what diuretic would be recommended? So I would not be comfortable using thiazides or furosemide because of the hypokalemia component and muscle cramps. I will be using potassium sparing diuretic, that is spironolactone in the patient. And along with this, we can also use furosemide. I mean, that is a supportive drug that could be used in especially those cases where spironolactone is not working alone. Ideally, you should be trying monotherapy with spironolactone reaching up to the maximum dose. Then one of the side effects of spironolactone is gynecomastia. And more importantly, cirrhosis patients, male patients of cirrhosis can also have higher amount of estrogen, and that higher amount of estrogen can explain that gynecomastia component would anyway be present and can be worsened by spironolactone. So instead of using spironolactone, you can be using eplerenone as well. This is itself a question, pharma/medicine, that a cirrhotic patient with gynecomastia and is having also an ascites, what would you prefer? So we are already, initially we thought we'll use spironolactone, but the gynecomastia component can be affected. And because I told you that estrogen levels are elevated in patients of cirrhosis, this also explains the development of spider nevii. In one of my previous discussions, I've said that spider angioma or spider nevii can be seen on the superior vena cava distribution of the patient. In the exam, he said which hormone would be explaining this development of these lesions. Your answer would be estrogen. Now, another drug which can be used to my advantage is amiloride as well. And he says that once initially it is monotherapy, then you can combine the two drugs as well, spironolactone/eplerenone.
with furosemide, and you keep on increasing the dose. Now, how much is the dose that can be increased? Suppose the patient is taking salt restricted diet, traditional dose of spironolactone is like 100 milligram, but you can upgrade to as much as 400 milligram. Nobody will ask you this mathematical value, but I'm saying that you would be using outrageously high values, much higher than what you traditionally use even in heart failure. So it's like 400 milligrams of spironolactone, 160 milligram of furosemide per day, and still the patient is having a ascites. Well, I'm trying to here define before you what do I mean by the word refractory ascites. I'll jot it down here only. Whenever I say refractory ascites in a patient, that means medical therapy is being used to the optimum maximum tolerated levels. The recommended dosage, I mean, they'll not ask you the dose, but I'm trying to tell you the fact that I have tried to max out the dose and still I'm not having an improvement in the patient. Now, in these circumstances, either I will have to plan tips or even a orthoptic liver transplantation. But before I do that, do I have another drug which I can use before I say that, okay, we might have to go in for a large volume paracentesis, or we might have to go in for tips. So we can be at this point of time using a vasoconstrictor. Now, midodrine, as you know, is a vasoconstrictor. What it will do is that it will constrict the splanchnic blood vessels. If you constrict the splanchnic arteries, then the blood supply to the veins will also be lesser. And if the venous flow is lesser, then the portal hypertension component is related to veins only. I mean, if you reduce the blood supply to the veins, then the pressure will reduce, and the reduction of pressure will reduce the ascites component as well. So, I mean, this is one of the reasons why midodrine and clonidine, I mean, clonidine, personally speaking, I'd not be very comfortable writing to a patient like this. But yeah, because it's given in medical literature, I just wanted you to be aware of the fact that vasoconstrictors do have a role in medical management of a patient of ascites. The logic is reduce the splanchnic flow. Obviously, I'll not reduce it to the level that I get a gangrene, right? But at the same time, if I can reduce it just above the critical threshold, it's lesser, but never below that level of perfusion, so less that the organ survival is hampered. Organ survival is very much there. Then the splanchnic circulation, venous pressure will also be less, and the ascites component would be less. But if I've exhausted all these resources, maximum dose of spironolactone, maximum dose of furosemide, vasoconstrictors also put in, then I will have two options. One, I can go in for LVP, that is large volume paracentesis. On reading the word LVP, it is not low volume, it is large volume paracentesis. And the usual query in the minds of most doctors at this point of time is that, sir, if you will remove such a large amount of fluid from the body of the patient, would you not cause substantial amount of dehydration? Because after all, it is fluid from the patient's body itself. I mean, you're removing, let me say, 3 liters of fluid, 4 liters of fluid from peritoneal cavity in a day. If you remove such a large amount of fluid, agreed that the fluid is in the peritoneal cavity, but it's after all patient's fluid only, no? So if you're causing a dehydration, would it not cause a rise of ammonia concentration? Remember, in cirrhosis patients, already ammonia concentration is elevated. And in this chart, by causing dehydration, ammonia concentration will rise. And would you not trigger asterixis? Yes, the risk is very much there. If I do a large volume paracentesis, I can have a side effect of hepatic encephalopathy being triggered in the patient, which obviously will result in query from your side, sir. On one hand, you're saying you will do the procedure and you causing such a huge side effect, then why would you do it? Well, I will not allow this to happen. How can I prevent this from happening? What I can do is that with the procedure, I can also be giving salt-free albumin. Now, let us see how salt-free albumin will work. Do not focus on the word salt-free here, focus on the word albumin. What albumin will do is, it will increase the oncotic pressure. It will draw the fluid, whatever is the ascitic fluid, it will cause the fluid to move back into the intravascular circulating space. So on increase of oncotic pressure results in increase in the circulating fluid volume. Now just read the statement that I said. I'll repeat the statement once again. I said if I upgrade the oncotic pressure, if I cause this ascitic fluid to move back into the intravascular circulating fluid volume space, then what will happen to the magnitude of dehydration? Lesser, right? And if the magnitude of dehydration is lesser, hepatic encephalopathy and asterixis can be prevented. So we do not do a large volume paracentesis alone. We do it with cover of salt-free albumin, and the logic of salt-free albumin is it replenishes the circulating fluid volume. Replenishment of circulating fluid volume reduces the magnitude of dehydration, and therefore my patient would come out of, I would say, this mess. And another step or another procedure which will obviously be expensive and will require expertise is TIPS, that is transjugular intrahepatic portosystemic shunt. Now, as far as TIPS is concerned, I mean, the query is now, should I go for LVP with salt-free albumin or should I go in for TIPS? Then one of the advantages of TIPS is that it is superior to prevent reaccumulation. Lots of time you do a ascitic tap, you remove the fluid, you send this alcoholic cirrhosis patient back home, and the fluid will be back in few days again. Lots of time the patients may not be able to continuously take a salt restricted diet and may not be regular with his medicines or tablets that you've written also. So if the fluid comes back, then you might have to repeat the procedure again, and then repeating ascitic tap is emotionally taxing. No, you are putting a needle in the tummy, patient is watching it. He feels emotionally drained because of it, and then he has to lie still so that you can remove the fluid from the parietal cavity, and he can't go to the bathroom at that point of time. I mean, restricting mobility of somebody, no, we normally we don't realize our freedom, no, but if somebody asks her to lie still on the bed for even half an hour, after half an hour we will become fed up. Similarly here, if you are asking this person that okay, I will do a tap again, it will be emotionally very draining on the patient. So he'll say, sir, don't you have a permanent solution? I do have a permanent solution, that is TIPS. But the problem with TIPS is then another one, that is if you are going to be shunting the portal vein blood into the jugular vein, portal vein blood is rich in ammonia. If you're gonna shunt the ammonia rich blood into the interjugular vein, you again have a side effect of hepatic encephalopathy. So you can see why I was saying that we should register patient for orthoptic liver transplantation early on with a Child-Pugh score of more than 7 or MELD score of more than 17, is because even if you are trying to manage these patients, there are some side effects which are I would say difficult to manage. As far as the mortality reduction is concerned, when you compare, there have been clinical trials where they have compared mortality reduction with large volume paracentesis versus mortality reduction with TIPS procedure, and they found that the mortality reduction with both of them is same. So as such, for point number 5, I cannot at this particular point of time, on the basis of evidence, say medicine say that okay, for refractory ascites best treatment is LVP, or I cannot say best treatment is TIPS because mortality for both of them is same. So till there is another trial, maybe a bigger patient size and a multi-centric trial or randomized control trial where we have more data coming up, in the MCQ, I cannot say that treatment of choice for refractory ascites is LVP or TIPS, and neither do I expect the examiner to ask that. First option from practical perspective, let me say, if he still gives a question like this, what is best for refractory ascites? First option that I would like to answer is still a large volume paracentesis, because it is easier done in your ward, and all you need is, your expertise, your skill, a bit of instruments, and salt-free albumin, and you will be able to at least reduce the distress in the patient. So from the practical perspective, first answer is large volume paracentesis, though head-on clinical trials, peer-based review, as they say, has not shown any mortality reduction at this point of time. The next point that I would like you to remember is that beta blockers tend to increase mortality whenever person has gone into refractory ascites. You can see that timing is very, very important, because in the earlier part of the discussion, I was saying that beta blockers are useful for non-bleeding varices. So when I say non-bleeding, it means patient is having compensated cirrhosis. When the varices will burst and there would be severe manifestations of portal hypertension, that means decompensated. So the message is beta blockers are good in early part of patients of cirrhosis when they have not developed full-blown features of portal hypertension. But once person develops refractory ascites, then beta blockers have been shown to increase mortality. This is a very paradoxical statement, and again, the queries from most students is, sir, how do we decide? So all I can say is that if you notice that the person has already bled once, you notice that the person, if he has already bled once, you will go for endoscopic varicose ligation. If he has already suffered from ramifications of the disease, why to give beta blockers? Beta blockers have a preventive role, but once the problem has crossed a threshold is varices are burst, threshold is now the ascites has become converted into refractory ascites. That is when beta blockers are not to be used. And then we'll discuss about the aspect of SAG, that is serum albumin ascites gradient. Now, serum albumin ascites gradient, as the name suggests, would be that you would be subtracting the amount of albumin in the ascitic fluid from whatever is the serum albumin values in the patient. And there can be two possibilities. Either he will say, like in plural effusion, you read the word transudative, exudative. Now here they don't use the word transudative, exudative, but rather the concept is still the same. I mean, the concept is still the same, that whenever it's going to be inflammatory causes, then it's going to be the right side of the discussion, SAG value less than 1.1 gram per deciliter. If it's going to be transudative variety like portal hypertension, the values would be more than 1.1, and I'll give you the reasons for that also. You see, if the mathematical value in the exam is given to be more than 1.1, then you will also be checking out the ascitic fluid of the patient for the amount of protein in the ascitic fluid. There can be two possibilities further. One possibility can be that the amount of fluid in the ascitic fluid is less than 2.5 gram per deciliter. Second is more than 2.5 gram. And my subsequent information will make more sense to you. Let's take up a case of congestive heart failure. Let's stop talking for cirrhosis at a moment. Let's take up a case of CHF. In any patient of congestive heart failure, because of the backward pressure, I'm saying forward failure, backward failure, there would be increased pressure in the portal vein on the long run in any case of chronic congestive heart failure. So higher pressure will cause albumin to move out into the ascitic fluid, which is the reason why the ascitic fluid albumin values would be more than 2.5. Similarly, if a patient is having hepatic vein thrombosis is responsible for Budd-Chiari syndrome. So when a person is having early Budd-Chiari syndrome, because of the higher pressure, the ascitic fluid would be having a higher concentration of albumin. But in the same patient, there is scarring present in the sinusoids, then there cannot be any migration of albumin. You see, why in late Budd-Chiari syndrome would you be having less albumin in the ascitic fluid is because now scarring is occurring, so the movement of protein would be affected across the sinusoid. But initially, you would be having is a manifestation of increase in the amount of protein in the ascitic fluid. Similarly, if I talk about inferior vena cava obstruction, this could be due to a tumor, it could be inferior vena cava thrombosis in a patient, / whenever I say sinusoidal obstruction, in all of these patients, the increased hydrostatic pressure will explain why the amount of protein in the ascitic fluid could be more than 2.5 grams. At this junction, the query from a lot of people is, sir, you are saying increase protein, and in pleural effusion, you say increased protein is exudative. Sir, when I say pleural effusion is exudative, I mean inflammatory protein. Inflammatory protein would mean like antibody is present, fibrin present. At the moment, I'm not talking about fibrin. I'm talking about albumin. Exudative pleural effusion, when you read, it's gonna be rich in fibrin. No, that is why it tends to clot on standing. But this fluid that I'm telling you, the ascitic fluid, this is rich in albumin. It doesn't have fibrin, so it will not clot on standing. The most important reason for why we are discussing this is anyway alcoholic cirrhosis, because of the scarring present. There would be no leakage of proteins, because of which the ascitic fluid value would be relatively lesser. Another thing that you have to remember here is, suppose a person is having colorectal cancer. You very well know colorectal cancer can metastasize to the liver, or even breast cancer can metastasize to the liver for that matter of fact. So if a person is having massive amount of liver mets, then again the scarring that occurs associated with liver metastasis could cause less movement of protein, because of which the protein values would be lesser. So half the game in multiple choice questions would be that whenever he's gonna give you a scenario where this mathematical value is turning out to be more than 1.1, all you need to check in the question is how much is the serum albumin value given and the ascitic fluid albumin given. You need to subtract, right, from the serum albumin, the ascitic fluid albumin, you get a SAG value. If it is more than 1.1, you have already checked out how much is the ascitic fluid albumin. Is it more than 2.5? Is it less than 2.5? It is less than 2.5, that means scarring part has occurred. If it is more than 2.5, it means that the transudative pressure is more, there is no scarring, so albumin can move across. And if you can, try and write down this information, this would become much more clear to you. The logic for the middle, I repeat once again, is transudative. But if there is scarring present, then the value would be lesser. But in both of them, the mathematical gradient you will have to calculate will be more than 1.1. Now, suppose you get a scenario where it is less than 1.1. Then what are the conditions which would be associated with it? I'll give you a mnemonic by which you will be more capable of remembering it. You need to remember the right side equally. I mean, the right side is equally important. The first one is bile leak, then is nephrotic syndrome. Now, nephrotic syndrome traditionally is responsible for transudative pleural effusion. No? Nephrotic syndrome causes transudative pleural effusion. So the query most people is, sir, if it causes a transudative pleural effusion, why not did you include nephrotic syndrome on the left hand side, which you were saying is related to transudative and increased hydrostatic pressure? Well, the point is in nephrotic syndrome, serum albumin also becomes less and ascitic fluid protein also becomes less because there is a urinary loss, no? So both parameters reduce to the level that the value turns out to be less than 1.1. Agreed that nephrotic is a cause of decrease of serum albumin, but even the ascitic fluid albumin is reduced dramatically to the value coming as less than 1.1. The next one is peritoneal carcinomatosis. Earlier I was talking about metastasis to the liver. But if a patient is having cancer that metastasizes to the peritoneal cavity, to the omentum, then in those circumstances, it will cause inflammation, and the inflammatory part will cause the ascites component to come up. Let me just jot down few of the important causes of peritoneal carcinomatosis that could be written in the question. It could be like mesothelioma, or more importantly, ovarian cancer. It is spreading to the peritoneal cavity, causing a malignant ascites. Just like you read, malignant pleural effusion is seen with adenocarcinoma of the lung. Similarly, malignant ascites is commonly seen with ovarian cancer. Similarly, you could be having drop-down mets in stomach cancer. You know about that Krokenberg tumor, but the same drop-down mets on their way could land up in the peritoneum, could land up on the omentum as well, and there could be more inflammatory fluid present, due to which the SAG values would be less than 1.1. The next condition that I'm writing here is severe enough to even cause a black colored ascitic fluid. Pancreatitis, especially necrotizing pancreatitis, could be having a very ugly brownish black ascitic fluid present in the patient. And then would be tuberculosis. In tuberculosis, there would be tubercles in the peritoneum. These tubercles in the peritoneum would cause irritation and would cause ascitic fluid to be present. The causes in green that I mentioned on the right are relatively easier to remember, like malignant ascites with ovarian cancer, tuberculosis as a cause, or nephrotic syndrome. So most of the time, if the question will come and has come in one of the INISET, is that they made you calculate this SAG. And how do you do that? From serum albumin, which was given in the question, you just need to subtract the ascitic albumin value, and simultaneously, depending on the ascitic albumin value, more than 2.5 or less than 2.5, the logic I'm saying once again, transudation versus scarring present is the concept by which you will be able to correct the questions. So this is what I would recommend you to note down, though you have printed notes at your disposal, but you won't be able to retain this otherwise. So it's always a good idea to put it, jot it down on a small stick on pad, keep it somewhere, the wall technique to be used, and focus on the data on a regular basis, so that when you read this question, it's going to be longest, 4-liner, 5-liner question, but he's testing your mathematics and he's testing your presence of mind here, so that you are able to answer the question with the right amount of temperament that is required to solve it. Next, I'm giving you a clinical scenario where I have a patient of refractory ascites on max dose of furosemide and spironolactone, and he started having fever. There's also an increase in the girth of the abdomen of the patient, and simultaneously even altered mentation or encephalopathy has been noted. The question arises, why is he having this fever and why there is a sudden worsening of the patient? Well, let me just diagrammatically represent this here. You in your OPD today had a patient with massive ascites, everted umbilicus, and just symbolically try to show, let me say, 2 liters, 3 liters, 4 liters of fluid in the peritoneal cavity of the patient. Depending on the height of a patient and build of a patient, the massive ascites fluid can vary. Now, the problem in this patient is that, let me say, these are the loops of the bubble. These are the loops of the bubble which are floating in the ascitic fluid. Now, inside these loops of bubble is bacteria, that is E. coli. What can happen is that this ascitic fluid is rich in nutrition. So there can be transmigration of bacteria. Usually this transmigration of bacteria, that is E. coli that I'm talking about, will initially occur to the lymph nodes. And once that happens, the bacteria moving onto the lymph nodes, the security system will come in, and the security system will try to kill this bacteria, but some of them might actually come over into the peritoneal cavity as well, and therefore the body will try to launch an offense, that is, there would be neutrophils now also coming in the peritoneal fluid, because there is bacteria reaching via the peritoneal lymph nodes, or I would say lymph nodes at porta hepatis, retroperitoneal lymph nodes are teeming with bacteria. So the security system is attacking it. Some bacteria are escaping into the ascitic fluid, so the security system is also following it. And if you have pus Pus means dead neutrophils. If you have the dead security system in the peritoneal cavity, my patient is developing a peritonitis, because of which there is a fever, there is sudden increase in abdominal girth, and later on the patient might even progress into septic shock as well. They could be worsening, increase in the ammonia concentration in the body, leading to hepatic encephalopathy trigger as well. All this that I've said before you is bad prognosis and is technically called as spontaneous bacterial peritonitis. Normally, I write the name of the topic and then I start describing it. But because they have given a question related to this topic, so I thought that I first begin by describing the case and then give you the diagnosis. SBP is an unfortunate complication due to transmigration of E. coli via the edematous bubble wall. You could have direct migration by the edematous bubble wall, or it could be movement to the lymph nodes, and then from the lymph nodes the security system fight going on. That could explain the peritonitis component. Aiding you in the diagnosis in this particular case was that because the patient has deteriorated suddenly, you wanted to know what is the source of fever, so you decided to do a abdominal paracentesis and send it to the laboratory for culture. But in the ward, you decided to check it under a microscope as well. When you looked under the microscope, you could not believe your eyes, because what you were seeing was a large number of neutrophils. I mean, neutrophils have no business to be in the peritoneal fluid. No, here what you're noticing is more than 250 neutrophils present per cubic millimeter. I mean, traditionally you read about neutrophils in acute bacterial meningitis in the CSF, but today I'm teaching you neutrophils in the peritoneal cavity. I will send the sample for gram stain, but maybe tomorrow morning the micro department will be processing it. So I'm not going to wait for the culture report to come. I need to start antibiotics right away. You will send a sample for gram stain, cytology, and culture, and cytology will show large number of neutrophils present that you can see under a microscope, which is kept in your ward itself. And I need to, on a priority basis, start this patient on antibiotics. This case basis has been asked both in FMG exam as well as in NEET PG as well as in INISAD. It's just that sometimes they have simple made the question easier by saying how much should be the cell count to say that it is SBP. That's more than 250 neutrophils per cubic millimeter. That was NEET PG 2022. And in the FMG exam, they gave a scenario like this: a patient of massive ascites having fever, abdominal girth occurring, and then he's suddenly becoming, I mean, there's worsening of the mentation of the patient. What could be the reason? So a lot of people thought it is hepatic encephalopathy. Yeah, hepatic encephalopathy will occur in these patients as a complication because the liver is decompensated. I need to go in for not an exploratory laparotomy. Obviously, I mean, this is not a secondary peritonitis. I need to go in for IV ceftriaxone in these patients. And he says that how can you prevent this from happening? So there are two ways by which I can reduce this. First and the foremost is that next time you get a patient with refractory ascites, plan a paracentesis early on, large volume paracentesis early on. Ideally, you should be doing paracentesis in the first 12 hours of admission in a person with massive ascites, especially if it is a recurrent one. Remember, I was telling you, massive ascites patient came and I can go in for large volume paracentesis versus tips. But finally, I gave you an answer that what will you answer in the exam? If both are given, your answer will be LVP. One more reason why LVP is recommended is because it has been shown to reduce the incidence of spontaneous bacterial peritonitis in the patient. Paracentesis should be done in the first 12 hours of admission in any case of refractory ascites to prevent the development of query suspect, that is spontaneous bacterial peritonitis. The second way to prevent this is, suppose you cannot do paracentesis, you are busy in the ward, you are the only resident on duty, and a tremendous amount of workload, and there's a lot of traditional COVID-19 patients, and then MI happening, pulmonary embolism, abdominal emergencies coming. You will then try to buy some time by giving norfloxacin in the patient as well. So just remember the cutoff here, well, that's important one. And second is the clinical profile that I've described before you. And now let's look at another version which they had given in the exam. Let's look at another patient who is also having refractory ascites. Whenever ascites becomes refractory, that means now the person has become decompensated. In this person of refractory ascites, we are having a progressive decrease in the urine output. He is satisfying the criteria for acute kidney injury. This would be relatively easy. I said refractory ascites patient is having acute kidney injury. Serum creatinine is progressively rising. and the urine output of the patient is decreasing, so the diagnosis of the patient would be easier for you to give. In this case, that would be hepatorenal syndrome. There's a full separate video on the revised diagnostic criteria for hepatorenal syndrome. So if you want to get into the entire criteria, that will take a long time. So I have not included this in rapid revision here, but those newer updated diagnostic criteria are given in the main section of the app. From the exam perspective, one, you should be able to pick this up, and second, they've asked what is the treatment for this, because ultimately, after all, he'll like to know about the first intervention to be done. So I would like to give this chap salt-free albumin. Why? Because I want the fluid to go back into the circulating system, circulating fluid volume to be increased. And how will that help? It will improve the perfusion of the kidney. If you improve the perfusion of the kidney, then the renal failure would become relatively lesser. Hepatorenal syndrome causes pre-renal variety of AKI. So albumin is increasing oncotic pressure and reducing the incidence of pre-renal azotemia in the patient. Along with this, we will also be using a vasoconstrictor. The vasoconstrictor that can be used here is octreotide. What it will do is that it will constrict the splanchnic vessels. So if the arterial flow will be lesser, the venous flow will also be lesser. If the venous flow is lesser, the pressure in the portal circulation is lesser, and therefore the ascites component will also reduce. You see, treat the problem. You are trying to treat the problem in the patient. So the logic behind why do you use octreotide or midodrine in hepatorenal syndrome is mainly that you are reducing the pressure in the splanchnic circulation, reducing the portal vein pressure, and as a result of it, because if arterial flow is lesser, venous flow is also lesser. That's the simplest way to understand that. And if the venous flow is lesser, the pressure will also reduce, and that will help in reducing the magnitude of ascites. And if the ascites component is lesser, then more will be the perfusion of the kidney, because ascites would be wastage of fluid in the peritoneal cavity. So HRS is albumin, octreotide, and midodrine that should be used. Another complication that can be developing in these patients is hepatopulmonary syndrome. Now, this is relatively easier to pick up because a known case of cirrhosis, refractory ascites, is deteriorating and is ending up with the respiratory distress. Oxygen saturation of the patient is falling. In hepatopulmonary syndrome, there is a triad, a very interesting triad. As far as the pathogenesis of this is concerned, the intrapulmonary shunting that happens in this condition, if you're interested in knowing regarding what I mean by the word intrapulmonary shunting, you will have to go to the main video. But here the concept is that in simpler words, I can put like this, that when the liver will fail, the poor kidney will also suffer and the lungs will also suffer. And the first manifestation of this chap would be that there would be breathlessness, but this breathlessness will be worsened in sitting position. Traditionally, you read about orthopnea in heart failure. You read about tropopnea in massive pleural effusion. But today I'm teaching you platypnea. The last time I've said platypnea is atrial myxoma. Platypnea was discussed in cardiovascular system with respect to a benign tumor of the heart, that is atrial myxoma. But platypnea is also found in hepatopulmonary syndrome. It's an intrapulmonary shunting that is occurring. Along with this, you will also read a very interesting term, that is orthodeoxia. Now, traditionally we read about orthopnea, but here he is talking about orthodeoxia, and this is again because of the intrapulmonary shunting. Definition of orthodeoxia is that you can attach a pulse oximeter to the patient's finger and you can check for the SpO2 values on supine and then on sitting, and you will notice that there will be a fall in SpO2 values by approximately 5%. Or instead of SpO2, the another definition is fall in the PO2 of the patient. The PO2 will fall by at least 4 millimeters of mercury, or the overall absolute value, partial pressure of oxygen, will be less than 80. There are three ways by which orthodeoxia is described, and I think it will be unlikely that they'll ask you these mathematical values, but I just wanted to sensitize you to the fact that all of this will happen when the patient sits up. And the logic behind that, well, you need to go to the pathophysiology component in the main section of the app for that. I mean, why that happens, the lower part of the lung and the upper part of the lung, they have a different ventilation perfusions, no? So here what happens is a gross change in oxygen saturation on sitting. The second feature that is present in these patients is cirrhosis. This cirrhosis that is occurring at the moment is D. D here means decompensated cirrhosis occurring. So like I said, bleeding esophageal varices, refractory ascites, and now I'm saying hepatopulmonary syndrome indicates a decompensated cirrhosis in the patient. The third is the triad, which is from the third component of the triad is pure physiology. That is intrapulmonary shunting occurring in these patients. That's because nitric oxide is produced by the cirrhotic liver. It dilates the pulmonary blood vessels. You will say, sir, if dilated pulmonary blood vessel, there should be more blood flow. Okay, but the RBCs in the center of the blood vessel. Imagine there is a micro blood vessel in the lung. I didn't intend to explain that because it's given in pathophysiology in the main section. But anyway, if I dilate a micro vessel in the lung, if it is becoming dilated, this is the alveoli. This is the source from where the oxygen would be coming. If you dilate the blood vessel, the RBC which is traveling bang in the middle. You see, RBCs would be traversing like this. Some would be close to the wall. Some would be in the middle of the blood vessel. So RBCs which are away from the alveoli, they would be if you dilate the microcirculation of the lung. No, why ventilation perfusion ratio is so stressed upon in physiology is because if you dilate the blood vessels which are present in the lungs much more than normal, then the dilation of these blood vessels is counterproductive because RBCs which are traveling away from the alveoli, they will be traveling and would be getting less time to get oxygenated. You see, RBCs have to catch oxygen, whatever is present in the alveoli of the patient. So because these blood vessels are dilated, the RBCs will, due to pressure, they'll move forward before they're able to catch oxygen. So lots of these RBCs are without oxygen, and that is what I mean by the word intrapulmonary shunting. Traditionally, shunting word, no, when you read congenital heart disease, we read in our mind shunting. When I was your age, shunting was like left to right and right to left. When I read the word intrapulmonary shunting first time, I was clueless. I mean, where is the blood going? He is writing dilated blood vessels. The logic is dilated blood vessels. The blood vessels which are farther away from the alveoli will be having lesser chances of getting oxygenated. They move without oxygen, and the function of RBC is oxygenation after all. No? So in these patients, you rather have is a decrease in oxygen saturation. So hepatopulmonary syndrome is a triad which is to be remembered. And then there is a very interesting investigation that is asked for hepatopulmonary syndrome. I mean, we don't read about this on a regular basis. This would be called as a bubble contrast echocardiography. I mean, we don't read about it on a traditional basis, but this is one of the important tests that is helping you identifying HPS in a patient. So my patient is decompensated at this point of time with kidneys also getting affected and lungs also getting affected. If lungs are affected, well, he's had it and he will require I would say, a ventilatory support. Now, in the progressive downhill course of this patient, there is development of hepatic encephalopathy. If he says, what is the early manifestation in these patients? So, most of these patients would be confused, and you will notice that lots of time when you talk to them, the person will sound very happy, euphoria. It will be as if patient is unusually very happy. There would be changes in the personality of the patient. I mean, the family member is saying that, I don't know, I mean, this guy looks very boisterous. And you will also notice that there would be a change in the sleep pattern of the person, like he'll remain awake the whole night and would be sleeping the whole day, though we doctors also do the same. No, half the time you guys would be awake the whole night and sleeping in the daytime. So one of the early features that you encounter in hepatic encephalopathy is confusion, changes in personality. Another feature apart from personality change would be alteration in the sleep awake cycle. Asterixes would come later. Initially, the changes are relatively subtle or relatively milder, and they might be missed by the family member also. So in this known case of cirrhosis, what you're doing is you on a piece of paper are just jotting down these random numbers like 1, 2, 3, 4, 5, 6. And if I ask you, like normal person like you and me, to join them, you can join 1 with 2, 2 with 3, 3 with 4, 5 with 6, and so on. But if you are gonna ask a patient who's having a possible query at the moment hepatic encephalopathy, then he will fail to join them or will make a mess out of it. So the test that I'm trying to teach you here and has been asked in the exam is called as number connection test, or you can, instead of numbers, you can use alphabets also, depending on the education. Who is Hindi medium, ka ka ga, something like that. So the number connection test is trying to tell you that the parietal lobe of this patient is affected. You see, ammonia concentration is high, so it is affecting the neuron functioning in the non-dominant parietal lobe, and therefore apraxia was what I was trying to test here by number connection test. When I ask this patient simple thing like if I show him my cell phone, something as simple as a cell phone, or even to a villager, I mean, everybody in India knows what is a cell phone, right? The point is, I'm showing him as a cell phone and I'm asking, what is it? He knows it is a cell phone, but he'll be fumbling. His brain will be fumbling for words. His neurons are searching for that word. What he knows by facial expression, this looks familiar. Phone is something very familiar object. but he will not be able to name it. So anomic aphasia, just to make it on the lighter side, like you go to anatomy viva, they give you a bone and say, okay, tell me everything about it. So you would have studied about that bone, anatomy bone, for the whole night, but still we are fumbling for words. Our brain is searching for those words to describe what is anterior, what is posterior, but that's because of information overload. Here it is a toxin which is causing encephalopathy. So the term here is anomic aphasia. This anomic aphasia means difficulty in naming an object. If I say Broca's aphasia, he'll mostly be mum or will be, you don't expect him to vocalize. That's why you say the word motor aphasia. But when it says anomic aphasia, it would be difficulty in naming an object. After this, asterixis will start coming up. Asterixis is also referred as negative myoclonus. Let me just jot it down because we always read about positive myoclonus, myoclonic jerks. But this is again a very peculiar term, negative myoclonus, for described for asterixis. And once the person goes into stupor and finally into coma, then this asterixis part is going to disappear. Hepatic encephalopathy can be picked up on basis of various methods. So let's look at what the test that you would be doing. One will be blood ammonia levels, but for this you need a good lab and the sample processing. If it is delayed, then the ammonia levels might be even falsely normal as well. Blood ammonia levels in this patient, assuming you have a good lab and the processing time is minimum, the blood ammonia levels are elevated, though this test is notoriously lots of time normal as well. When you are going to do a EEG in the patient, because ammonia is affecting the neurons, you would be having special waves which have been asked in the exam. This is called as triphasic waves. I would like you to go to the EEG section in neurology, right in part 1 of neuro. When I've described EEG before you, I've talked about triphasic waves and how they look like. Now, for management of these patients of hepatic encephalopathy, I will have to put a nasogastric tube in this chap who is comatose. And what I'm going to give to him initially will be lactulose, which is the ammonia binder. You are aware that the major site of ammonia production in the body is the gut bacteria. Ammonia is detoxified by the liver, but where is it produced? It is mainly produced by the gut bacteria. So I am trying to bind down to the ammonia, and lactulose apart from this will also cause a bit of diarrhea. So the fecal matter is passed out, bacterial load in the gut is lesser, and if the bacterial load is lesser, then the ammonia production would also be lesser. Similarly, we will also read about rifaximin being used here. Now, why am I using an antibiotic, a bacteriostatic antibiotic? Not because there is any infection, but I just want to reduce the bacterial load. Neomycin and rifaximin, they are bacteriostatic antibiotics. They would be given by the NG tube and they will help you reduce the load of bacteria because the major site of ammonia production in the body. This was a very simple question in paper 1 in FMG. What is the site of ammonia production? And a lot of brilliant guys, they casually answered in the exam, liver. Sir, in the liver, ammonia is detoxified. No, liver is the site for detoxification. The major site of ammonia production is going to be answered by you as the gut bacteria. I would like to reduce the load of bacteria in the gut of this patient. This also explains why constipation can worsen or trigger hepatic encephalopathy. Like I said, large volume paracentesis can trigger hepatic encephalopathy. TIPS procedure can trigger hepatic encephalopathy. So you will always notice that whenever you read about hypoxia triggers hepatic encephalopathy. So triggers could be multiple. Excessive use of diuretics. The logic is in excessive. Suppose I'm giving too much amount of diuretics to a person who is having cirrhosis. You see, giving excessive amount of diuretics going up to 400 milligram is a double-edged sword. Why I'm calling it a double-edged sword is if I give too much of diuretics and they remove water from the body, agreed that the ascites component will be improving, but I'm causing dehydration. It will spike the ammonia levels and can worsen and can cause asterixis to be triggered in the patient. So managing these patients will always be a challenge, and apart and over for this, you can also be using Lola in these patients. In Lola, O would be standing for ornithine. You can very well see that I'm trying to reduce the load of ammonia in the body in this patient. So ornithine and aspartate, they would help me in clearance of ammonia from the body. Along with this, because coagulopathy can be present to neutralize the bleeding part, because internal GI bleeding is again a big problem. Suppose he bleeds. Blood is a very good culture media. It will promote the growth of bacteria, and if you increase the amount of bacteria, more ammonia production. So excessive use of diuretics, or I can put one more, internal GI bleed. or it might be written large volume paracentesis. These that I have mentioned separately, they are the triggers. These are the triggers which can commonly be given in the question, following which hepatic encephalopathy or even TIPS procedure. I didn't write TIPS here because I've already written the data, but these could be some triggers that could end or result in hepatic encephalopathy to occur in a patient. And therefore, in the final message, I would like to say that orthotic liver transplantation would be one of the best bets by which I can save the life of this patient. And if that is not available, I would lose the patient, unfortunately. Next up is the topic of acute viral hepatitis, and the number one cause of this has been already told to you as hepatitis E virus, whereas whenever it comes to chronic hepatitis, it is hepatitis C. Do not answer hepatitis A as the leading cause of acute viral hepatitis because that would be answered from pediatric perspective. The usual presentation in this patient would be development of nausea, vomiting, fever, and most importantly, right upper quadrant discomfort. When I put my hand on the right upper quadrant of this patient, I'm also noticing that he's having a tender hepatomegaly. The liver of this patient might be palpable about a few centimeters below the costal margin. And I also evaluated this patient for any pedal edema, also for evidence of any ascites present. I did check for puddle signs, shifting dullness, etc. And also for Kaplan-Meier. I wanted to be sure that is it acute liver damage or is it acute on chronic liver damage presentation. So there were no signs suggestive of chronic liver disease in this patient. Now I will be doing a workup of this patient. Not in all cases would you be having hepatitis E. It could be hepatitis B also after a sexual contact, and the patient might deny that information, or most importantly, may not be comfortable revealing that information of a casual sexual encounter before you. So you will run a battery of tests by which you will be able to check for at least the following three viruses. The test that I'm describing before you, as you can see on the slide, will be test for hepatitis A, hepatitis B, and hepatitis C. The test for hepatitis A that I'll be writing for this patient is IgM class of antibody to hepatitis A. For hepatitis B, I'll be writing two of them, that is surface antigen, and similarly, I'll also be checking for the IgM class of the antibody to the core antigen, because the combination of the two, hepatitis B surface antigen and IgM class of antibody to core antigen, helps you diagnose acute hepatitis B. I will also be checking for antibody to hepatitis C virus. There is no need for investing a lot of money and do a HCV RNA directly. Initially, I would be more comfortable doing an anti-HCV antibody in the patient. And let us see the first permutation combination here, which is that the patient is having surface antigen positivity and IgM class of antibody core antigen positive. So the clinical diagnosis in this patient and the combination of clinical findings and the serological evidence is acute hepatitis B. Subsequently, I can get a E antigen done also, but the point is at the moment I am just trying to do a cost-effective diagnosis of the patient, and acute hepatitis B has been identified. But in some circumstances, it would be IgM class of antibody to hepatitis A that may be detected. So it is acute hepatitis A, especially in pediatric age group, can occur in adults also. In case you are having only antibody to the hepatitis C virus, that means that this is acute hepatitis C, and it can progress subsequently to chronic hepatitis C. So that's always a cause of concern, because hepatitis C is more dangerous of virus. It's like it will cause a slow, gradual burning of the liver. That's an unofficial way of explaining it. A simmering fire, a gradual burning fire that may actually evade detection, because in a lot of patients of chronic hepatitis C, you might notice that SGPT may be normal also. But you still have to treat the patient, otherwise the progression would be pretty nasty, and these patients might progress to development of end-stage liver disease without any treatment. The main reason why I'm describing this particular slide is to sensitize you to the fact, and this is a line in Harrison, that if all of these three turn out to be negative, hepatitis A tested by IgM class of antibody, anti-HCV antibody, and hepatitis B surface antigen and IgM class of antibody to core antigen is also negative, this means that the diagnosis of the patient would be non-A, non-B, non-C, and that would be usually in favor of hepatitis E as well. So lots of time we may not be doing this test also if I want to make it I would say, if I don't have resources. Nowadays is the era of evidence-based medicine, though in clinical practice you will see lots of time we may not be running these battery of tests at all, especially after rainy season, after monsoon season. If you're having a flurry of cases of hepatitis E in epidemic proportion, we may not be running these tests, but considering evidence-based scenario, it was important that I describe this algorithm before you, especially the last entry is important. Now we will mainly focus on hepatitis B per se. And with respect to hepatitis B, I want to mainly draw your attention to the fact that they can give you a line diagram with respect to the course of progression in hepatitis B. The leading cause of transmission of hepatitis B would not be answered as transfusion. Agreed that the leading cause for transfusion associated hepatitis is the topic that we are studying, but this gives a false impression that, hepatitis B, the major route of transmission is blood transfusion. We prevent that from happening, no? I mean, we know that transfusion associated hepatitis is hepatitis B, but we try to prevent that by happening by going in for proper testing. So if he says what's the most common route of transmission of hepatitis B, you will notice that it would be written as percutaneous, and that would mean both sexual contact and then subsequently parenteral route of transmission as well. So this is TX, that means transmission. As far as the graphical representation is concerned, you will always notice this fact that the value of IgM class of antibody to the core antigen, where I'm putting the marker at the moment, will begin to fall, and it will take some time for the anti-HBs to appear. So there is a possibility, though in this case I have shown that both are very very close to 32 weeks approximately, but there is a possibility that when IgM class of antibody to core antigen is becoming undetectable, and the antibody to surface antigen is also undetectable, at that point of time the antibody that would still be present and would tell you that there is evidence of infection would be IgM class of antibody to the core antigen. We call it the gap period. What I mean by gap period is the gap between the gap that I'm highlighting here, the gap between the disappearance of the IgM class of antibody to the core antigen. And next up is a graphical representation with respect to hepatitis B. The leading route of transmission of hepatitis B would be sexual contact, or can be written as percutaneous. At this point of time, a common problem that I see, or the error that I see people making, is that they answer that the leading cause of transmission of hepatitis B is blood transfusion. So I agree to the fact that the leading cause of transfusion associated hepatitis is the topic that we are studying, but that does not mean the fact that this is also the number one route of transmission. The number one route of transmission for hepatitis B would be answered as percutaneous, and that would mean both sexual contact as well as parenteral route of transmission, and rarely there could be an accidental needle stick injury as well. With respect to accidental needle stick injury, our doctor can get infected also, and he can ask you the percentage of chances of transmission of hepatitis B. Just like with HIV, you know that the chances of transmission would be 0.3%. With accidental needle stick injury, the chances of transmission would be fairly high, up to 30%. And if the doctor has not taken vaccination, then he would be given hepatitis B immunoglobulin. If he is already vaccinated and he's having protective antibody, the protective antibody titer is antibody against hepatitis B surface antigen. If the value of this is more than 10 international units, then the person is safe. So I repeat once again, if a person is non-vaccinated, he does not have protective antibody, you need to give hepatitis B immunoglobulin to this healthcare worker. However, if he is already vaccinated, suppose he maybe took only one shot or two shots, you will check out the titer of this antibody. And if the titer of the protective antibody, the seroconversion antibody is more than 10 international units per ml, then no issues. I mean, the guy is safe, and there is no need for giving immunoglobulin to the patient. Suppose the antibody titer is less than 10. Let me say the value comes as borderline, or border report comes as 7 or 8 international units. Then what you can do, you can give a booster dose of hepatitis B. The message is immunoglobulin is mainly recommended for those people who do not have protective antibody in their system, and the main protective antibody, which in multiple choice question would be written as seroconversion antibody, is the one that I have just highlighted before you. Another interesting thing that you will see here would be, and follow my marker at this point of time, is that hepatitis B surface antigen will appear early. One of the earliest things to appear in the blood after the infection with this virus is hepatitis B surface antigen, and then it will disappear also, something like 24 weeks, but it will take some time for the protective antibody to appear. You can see the fact that when you can see one of the curve is going down, and then the subsequent protective antibody is taking some time to develop. So the period between these two is what is called as window period, or is also called as gap period. So most of the time the questions that can be asked on this topic can be with respect to the gap period slash window period. Gap period means, I'll repeat again, that surface antigen is not detectable anymore, and the security system is also not, showing up in the blood per se. So what would tell you that this person has had a hepatitis B infection would be an antibody that you can see superiorly. This would be antibody to the core antigen. So one in the previous year exam, what they did was, and I'll just do a color change here to explain that they had shown a curve like this, and one of the curves was present, the one which you can see with the green marker, and there was no labeling present on this green line, and the question simply said which antibody is represented here. The answer would not be antibody to the surface antigen, which would be represented unfairly. The green representation that I made before you is for the antibody to the core antigen, which initially will be the IgM class and then would be IgG class, and the transition from that would also represent that initially it's acute hepatitis and then it's chronic hepatitis. And how do you differentiate? I mean, when do you say acute hepatitis B or chronic hepatitis B, then serologically speaking, you need to have evidence of two things: surface antigen positivity plus IgM class of antibody to the core antigen. And same for chronic hepatitis B also, hepatitis B surface antigen plus IgG class of antibody to the core antigen. Very basic, very straightforward, but the markings I'll just do once again. The markings that are shown is initially it's the surface antigen rising and falling. The protective antibody is taking its time to appear, and in between the gap period, the antibody that I've highlighted is IgM class of antibody and subsequently IgG for the core antigen. Now, there would be a table that would be given in the book and has been discussed in the main videos also. So I'll just invest some time describing this table as well. And the third antibody that we are talking in this case is antibody to the core antigen. The first one is pretty straightforward. The first entry here is hepatitis B surface antigen positive and IgM class of antibody core antigen, and E antigen is also positive. This means guy is highly infectious because E antigen indicates replication. So the first entry, nobody would ever have a problem. This would be acute hepatitis B. The second entry I've said verbally is surface antigen positive plus IgG class of antibody, and E antigen is still working overtime in a sense that the virus is replicating. So the chap is having chronic active hepatitis. The third entry needs to be listened with lot of care. Focus on the blue arrows present here. My patient was identified as having chronic hepatitis B. So what I did in this chap with chronic hepatitis B was I told him, sir, your liver has started getting damaged and his SGPT values are rising. I mean, I got a PCR done for hepatitis B DNA and I found that the viral copies are present in substantial amount in the blood. So the virus is very much present and is causing damage as well. So I have decided to start this patient on entecavir, or instead of entecavir, we can also use tenofovir. Now, if I'll complete the course of entecavir in the patient, because I will kill the virus which was causing substantial amount of damage to the patient, you will notice a change. The patient who was previously surface antigen positive, after taking the entire course of my treatment, will start turning to be negative at this point of time because the virus load will become lesser. So the security system will begin to respond. So you can see the security system is present, the antibody against the surface antigen. IgG class of antibody was already present, that's a carryover. And you can also notice another change. So the virus was replicating. Now I have killed the virus, so E antigen is turned negative. So if you compare the second report and the third report, then the comparison between the second and third report means that my patient has shown response to treatment. I will call this as recovery. Why? Because the drug has worked and I've reduced the viral load in the patient. The next entry that I've shown is for mostly people like you and me who have taken vaccine. We've never had the virus exposure, but we are having protective. We took a subunit vaccine made by DNA recombinant technology. So we are having the security system present, and therefore antibody against surface antigen is present, and the protective titers, as I've sensitized you to already, is more than 10 international units. Why I repeated that again is because lots of time we doctors are very casual. We take like first shot is 0 and 1 we take on time, and the 6 month shot is usually forgotten, and we used to delay. We may delay actually. And I mean, I do have young doctors who say, sir, I forgot about the third shot altogether till I remembered it maybe 1 year later. Can I take it? So yeah, he can take it. But my point is, why are they recommending the shots at 0, 1 and 6 is because when you take it at a fixed particular time, the antibody titers would be more than the critical values that I have said. And in case one misses dosages or is not taking them at the appropriate manufacturer recommended times, then the antibody titers can be lesser. The next question is very interesting in a sense that everything is given to be negative except for IgM class of antibody to the core antigen. The first impression when I was a student your age, I read IgM class of antibody core antigen. I thought it is acute hepatitis B. I lost that marks in the question because the surface antigen was negative. So I asked myself, what is going on? I mean, why is surface antigen negative? Because the person is in gap period. The surface antigen was decreasing. The security system has yet not appeared. So it is the gap period which has been represented once again. And then another time in the recent INISET exam, what they did was everything was negative except for IgG class of antibody to the core antigen. Only IgG class of antibody to the core antigen. If this is the only antibody present, then there can be two possibilities. Either is a low level carrier. What I mean by low level carrier is that the surface antigen is present but is below the threshold of detection. I mean, every test has some particular level beyond which it will be able to pick up antigenemia. So if the critical level is lesser for surface antigen, then the test will turn out to be negative, or it could be a remote infection. It could be a remote infection in the past in this patient. Most of the time, the answer in the question would be, I mean, low level carrier was not in the options. It would be remote infection in the past. So though this table is taught in pathology also, from the recent exam perspective, I want you to remember this last entry that I mentioned. In fact, the last two entries are the ones which are of main interest, because in both of them the surface antigen and the security system is missing. You can see, I mean, if you get questions like this, you need to check up whether it's IgM or IgG class of antibody. If alone IgM class of antibody is present, you will say gap period. If alone IgG class of antibody to core antigen is present, you will say remote infection and / low level carrier if it may be present. I mean, it's unlikely that he'll give you a question where both may be present. That's possible in any side where more than one answer can be correct. Now, for treatment of these patients, the drug that I've told you is entecavir, and we can also use tenofovir for the patient. It's not that one is superior over the other. It's just that in some books entecavir is given, some books tenofovir is given first. Now, when would you treat the patient? Then in hepatitis B, please remember that you do not treat a person with acute hepatitis B. For acute hepatitis B, it is conservative management. You can give antiemetics to the patient. You can give IV fluids for dehydration if the vomiting part is very severe, and usually the recovery occurs. And most patients, the jaundice tends to disappear at the end of 1 month or even earlier. Now, acute hepatitis B, the recovery rate is 90%. But some patients might get converted into chronic hepatitis B. So, who is the patient who will require this drug treatment is that you will be doing a PCR, and the report of the PCR will say 2 into 10 raised to power 4. That is more than 20,000 international units of hepatitis B DNA per ml. And you will also get LFT done, in which you will be checking out especially the value of SGPT. There is a doubling of value of SGPT, just like in MI I say doubling of troponin I values, or for any other disease, for every disease we would like to go in for quantification if there's a marker available. So because for liver damage it is cytopathic effect of the virus, it is SGPT. So if both of these are given in the question, the BCR DNA values should also be elevated, and there's a documented evidence of cytopathic effect of the virus, then we will start medical treatment of these patients, and there would be recovery, as I have showed you in the previous slide. For hepatitis C, however, I want to tell you that if hepatitis C RNA is detected, you did a PCR hepatitis C RNA and it is detected, even if SGPT of the patient is a normal, even if it is normal, because as I said, it's a smoldering fire, it is a hidden fire, there's a fire in the liver, but it may not be detected by the sensor. And what I mean by the sensor is the blood tests. By blood test, I mean PCR will pick up the infection, but the cytopathic effect of the virus, the antibody titer keeps on fluctuating in these patients. So there is a possibility that enzymes may be normal also at the time when you have tested the patient. So even if the SGPT report of the patient is normal, still you would like to treat the patient. There were various genotypes present. And in the previous edition of Harrison, he had mentioned about ledipasvir, but in the current edition, he has mainly focused on sofosbuvir and velpatasvir for management of these patients. So a slight change, I mean, in a sense that earlier, especially for genotype 1 in 20th edition, it was ledipasvir, but currently in genotype 1, it is mentioned sofosbuvir and velpatasvir. For hepatitis D, most of the time there can either be two patterns of infection. If he says what is the route of transmission of hepatitis D, then your main answer would be the major route of transmission of hepatitis delta is parenteral, that is IV drug abuse. There can be two patterns of infection. Don't answer co-infection as the method of transmission. Co-infection is a presentation of the patient. In some patients, it could be co-infection. In some patients, it could be a super infection occurring as well. And when it comes to co-infection, there is a possibility that this guy can land up in fulminant hepatic failure. And one of the leading causes of fulminant hepatic failure is hepatitis delta. One of the reasons why I have described hepatitis D here is because this is the leading cause of development of fulminant hepatic failure. You all know that fulminant hepatic failure can occur with all of these viruses. But especially if he is talking about fulminant hepatic failure with respect to pregnancy, then you know the answer. Even the obstetrician would have talked about it, hepatitis E. But if he does not include the word pregnancy, just says overall, which is the number one cause for fulminant hepatic failure, don't answer hepatitis B. Don't answer hepatitis C. In hepatitis B, I told you recovery is the rule in majority of cases. In C, it will get converted into chronic hepatitis and cirrhosis and end-stage liver disease and the need of orthopic liver transplantation. But parenteral is the route of transmission. Whereas when I say co-infection slash super infection, it is a manifestation. It's a pattern of infection that will occur in the patient. And these two viruses, I mean, Delta virus alone does not cause a problem, but it's like in combination with B, it will start causing mayhem. And the drug that we use for management of this is alpha interferon. So just like we read about beta interferon for multiple sclerosis, alpha interferon for hepatitis D. And the treatment part, I would rate this as an important slide. So though the hepatitis B virus is well studied by you, the tables that I've highlighted even in pathology, I just thought I'll explain these aspects here. And next up, we'll be studying aspects related to gastroenterology. I'll begin by describing a barium swallow finding that was given, and let's look at the question as well as the barium swallow finding. Very, very irregular, I would say shaggy, irregular appearance or shaggy margins of the esophagus can be visualized here. Though most of you would be solving the question by just listening to this word shaggy margins of barium swallow, but let's look at the clinical information which was also given. He said a patient slash client with odynophagia, which is painful swallowing. There is no relief in this patient with multiple consults. During the medical history of the patient, you notice that he was an asthmatic on Foracort. That means, I mean, you read the word Foracort, that means steroids, right? So he is taking inhaled corticosteroids. Now, the problem with inhaled corticosteroids is that you are always supposed to rinse your mouth after usage, because otherwise one of the common side effects that can occur in the patient is esophageal candidiasis. So the question can be solved here on basis of either the clinical history. This is one of the common side effects that we see in inhaled corticosteroids contribute to esophageal candida, or a barium swallow finding is what I've also shown, which is shaggy irregular margins of the esophagus. As far as A is concerned, Zenkel diverticulum, there would not be any odynophagia present in the patient. Yes, dysphagia can be there, but to say odynophagia would be unlikely. Then in achalasia, he'll usually begin by describing a female patient dysphagia more for liquids as compared to solids. So again, it is being ruled out. And for esophageal angina, most of the time the description will be chest pain after eating food. And I mean, I agree that odynophagia you could have thought, but then esophageal angina or diffuse esophageal spasm, we have is segmentations in the esophagus. We have a nutcracker esophagus, which is a variant of it. And the image for diffuse esophageal spasm would be discussed subsequently. In this particular case, the barium swallow is showing shaggy margins, which gives credibility to diagnosis as option number 4, and the remaining options can be ruled out in this particular case. Now let's look at a couple of more barium studies here. As far as Zenker's diverticulum is concerned, we can call it a pulsion diverticula, and lots of time he can mix this up with the anatomical aspects as well. So let me show you a diagram from the anatomical aspects, which are some of the important common sites where it can be seen. The green here is the representation for cricopharyngeus, and these are the horizontally arranged fibers which are mentioned here. Now, if you look at the arrangement the way I have shown, just superior to the cricopharyngeus, there is a defect present, and this defect is the one which I'm talking about. This is Killian's triangle. On the other hand, he can also talk about this triangle which is mentioned inferiorly, just below cricopharyngeus. So I can put that up as a question before you while I'm doing the marking. The superior gap defect or the defect in the fascia that I've shown, or I can just say there are no muscles here, so there's only fascia present, no support of the muscles. This is Killian's triangle. This is the common side. And can you just tell me the name of this triangle inferiorly, which would cause it? I think by this point of time, you would have answered me anyway. that is Limer's triangle. So you could be having Zenker originating in either of the two sides. And one of the important reasons why patients of Zenker diverticulum would be presenting would be because of dysphagia. Now, you might have findings of regurgitation of undigested food few hours after eating. That's because the food would get stuck up in this area, and this would be undigested food. So the word that was mentioned was not vomiting of yesterday's food items, it was regurgitation of food items. Whenever you read about vomiting of previous day's food items, you are mainly thinking in terms of a pyloric stenosis. Like in carcinoma stomach, you will read about vomiting of food items that were consumed yesterday, so the items will be digested. But in this case, what I said was it would be undigested food that would be coming up. So regurgitation is what you read with respect to esophagus. Even in HLHA cardiac is regurgitation. In Zenker's diverticulum, it is also regurgitation. If the problem is in the esophagus, it's regurgitation. Otherwise, we use the word vomiting. Then patient might say that I always feel as if the food is stuck in my throat, and he might press on one side and say that I have to press, and then it causes regurgitation subsequently. Aspiration risk would anyway be present, bad smell from the mouth would be present, halitosis, and borboigomy in the neck would be present because there would be some air getting trapped as well. To confirm the diagnosis of Zenker's diverticulum, we might be using a side viewing endoscope, but if not, then a barium study would help you pick it up. So this would be a relatively easy diagnosis in the exam, Zenker's diverticulum. And now we will compare this with barium swallow, which is shown and is currently being focused. This would be where there would be a tapering present, and the tapering is having the configuration of bird beak. So this would be HLHA cardia. One of the highlights of this disorder would be that there would be dysphagia that would be more for liquids as compared to solids. Most of the time, he can also incorporate what is the leading cause of HLHA cardia. So do not answer idiopathic. The leading cause for why HLHA cardia occurs is autoimmunity. Don't straight away answer Chagas disease. So yeah, I mean, Trypanosoma cruzi transmitted by red ovid bug, Chagas disease is one of the causes. It could be related to lung cancer also. So you could have paraneoplastic reasons behind it also. So it could be like a paraneoplastic manifestation with lung cancer and then Chagas disease. But one of the primary reasons or the number one reason would be autoimmunity, and all autoimmune disorders are more common in female patients. In this condition, there would be a loss of inhibitory ganglia, and because of this, the lower esophageal sphincter tone will be increased. Can you tell me the normal tone of the lower esophageal sphincter? Giving you a few seconds. Normal tone of lower esophageal sphincter. The normal tone of lower esophageal sphincter would be 15 to 25 millimeter of mercury. In this patient, because there is loss of inhibitory control, the tone will be increased, which explains why food is not going down. The appearance is pretty straightforward. I mean, I don't think so that anybody can mess up or mistake this bird beak defect that is coming up. It is or a pencil tip that defect that is coming up. It is just that associated facts are the ones which are to be remembered in these patients. And a word of caution is that every time you read a question that describes a female patient with dysphagia, you have to be very careful in not, I mean, if barium finding is not given in the question, then don't straight away jump and answer HLHA cardia, because you will notice that even in the topic of scleroderma, connective tissue disorder scleroderma, where we have anti-nuclear antibody positive and then topoisomerase antibody also positive, it would be a female patient. Though there would be features like Raynaud's phenomenon also, then subsequently even sclerodactyly and pulmonary artery hypertension. But what I'm saying is that he can begin by saying dysphagia in this lady, which may be present described for both solids and liquids. I mean, the way patient will describe it, it's very difficult to say. I mean, patients don't say like this, now more for solid, more for liquid. It's that you have to guide them with help of questions so that they are able to answer accurately. But then lots of time patients are, they say everything gets stuck here and they don't give a finite answer to whether it's more for solids or for liquids. Now, in this question, he might mention that there is also findings of reflux esophagitis. There might be even heartburn, and along with this, he will also mention that the tone of the sphincter is lesser. Now, why is the tone of the sphincter lesser? Is because there is fibrosis in the lower esophageal sphincter. So my point here is that whenever you are gonna read about dysphagia in a female patient, do have a look at the sphincter tone given in the question in the absence of barium swallow findings. Esophageal manometry, a high resolution esophageal manometry would clinch the diagnosis. Along with this, agreed, other features will always be given. He will talk about Raynaud's phenomenon. He will talk about sclerodactyly or pitting scars in the tips of the fingers of these patients. But the word of caution is that don't make a diagnosis of HLIJ cardia in the absence of barium swallow findings right away. There might be a trick in the question. You might end up as Crest syndrome or scleroderma as a presentation. Even in Crest syndrome, where you have anti-centromere antibody, after all, there can be esophageal dysmotility present in the patient. The reason why the tone is lesser here is due to fibrosis, and in the inferior situation, I told you there is loss of inhibitory control resulting in this manifestation. Now, when you look at another image which is given, I'll just zoom into the image. This image I have put simultaneously because this is actually a barium enema having a bird beak. Now you know this from surgery, but still I thought that because of the contrast present, this should be brought to your attention. Bird beak appearance with respect to a barium enema should not be answered as obviously HL as a cardia because enema is coming up. I think I've given you substantial amount of time to pick up that this would be sigmoid volvulus. The details of sigmoid volvulus can be read up from surgery, whether it's clockwise or anti-clockwise. Most of the time it will be anti-clockwise. Like cecal volvulus is clockwise and sigmoid volvulus would go anti-clockwise. And you also get a coffee bean appearance, the radiological finding I'll show subsequently. But this was again a question where people did make an error in the FMG exam that he said bird beak appearance in barium enema, and people didn't read the question and straight away mentioned कि भाई HLA cardia ही होगा. So, I mean, I would call it a very ultra silly mistake, which should not be happening. Now, moving ahead, there is another barium swallow coming up in which you will notice that there is a filling defect present. And in fact, this filling defect, when I'm talking about esophagus, it becomes easy, that you'll say, okay, sir, this is a rat tail appearance. But the technical term that we use for this one is shouldering sign. Shouldering sign would mean that there is a irregular filling defect present. The term rat tail and pencil tip have been widely disputed in different books. So I would not like to go by those names like pencil tip and bird beak. I would rather say that in HLIJ cardia, you were having a smooth tapering. There was a smooth tapering that was occurring. Whereas in this particular case, where I've described the shouldering sign, I have said is irregular filling defect in the patient. This person is having progressive dysphagia. He is 55 years of age and he has been neglecting his symptoms. He did have halitosis. He did have regurgitation of food items. Maybe he landed with pneumonia in my hospital last time, and maybe he was incidentally COVID-19 positive also. So we thought it's a patch in the lung due to COVID-19. Turned out it was actually a pneumonia occurring in this patient, for which antibiotics were given and he recovered also, because lots of time even in COVID-19 initially antibiotics were being given. So I might be missing the diagnosis of carcinoma esophagus initially. In carcinoma esophagus, dysphagia is one of the prominent symptoms, but it occurs when almost two-thirds of the lumen of the esophagus has been obliterated. Let me say this is the esophageal lumen, and there is a cauliflower or a polypoidal mass which is growing. So what I'm saying is that when this tumor will occlude almost two-thirds of the lumen of the esophagus, that is when the dysphagia will be appreciated by the patient. So by the time the patient comes to you, a substantial amount of damage in the form of tumor remaining undetected is already present. It will erode into, or it will show extension into the deeper part of the esophageal wall as well. The treatment of carcinoma esophagus would be studied by you from surgery, and you very well know the subtypes here, that is squamous cell carcinoma and then adenocarcinoma. And most of the books mention squamous cell carcinoma as more common than adenocarcinoma. Obviously, in the lower part of the esophagus, it would be the adenocarcinoma that would be more common. Now you contrast this with another image in which you can notice that there is a filling defect present. So, but this filling defect is different in pattern as compared to the previous ones. I mean, one I was saying was a smooth tapering effect. Another one I was saying was an irregular filling defect that was present. And the third one that I'm showing is that there is a abrupt cutoff which is present. And I think, let me okay give you a history. This guy says, sir, I mainly have problems with the non-veg. When I eat non-veg items, like he's eating mutton, mutton biryani, for example. And if the mutton part is not cooked properly, then there's a possibility that there might be food impaction or meat impaction in this patient. So the condition that I'm talking about in this particular case is Schatzki's ring. And usually the location of Schatzki's ring would be in the lower part of the esophagus. If you read the theory part, you will notice that Schatzki's ring is a membrane. It's more of a membrane composed of mucosa and submucosa. It does not contain any muscularis propria, and this could be present in the distal part of the esophagus, usually at the squamo-columnar junction. Just get the details right. It's a membrane of mucosa, submucosa, lacking muscularis propria. That's the muscular part of the gut, and then it would be at the squamo-columnar junction at the distal esophagus. And one of the problems in these patients could be like food impaction or meat impaction that could be occurring in these patients, and dysphagia also, which could be present since birth but was never identified in earlier times. So when it comes to the defects present, we need to remember the aspects which I mentioned here. And Schatzki's ring, why I'm saying the word again is because you should not be mixing it up with the traditional Plummer-Vinson syndrome. Now, Plummer-Vinson has been widely discussed in patho and surgery, so I'll not go into it. It's an upper esophageal web with coileonychia, a spoon-shaped concavity in the nails, present with iron deficiency anemia in the patient. And in Plummer-Vinson syndrome, it is the web in the upper part of the esophagus, whereas in Schatzki's ring, I was describing a lesion at the squamo-columnar junction. It's the distal esophagus which is involved here. The next image, which is currently before you, you can pick up easily that coffee bean appearance. This would be an X-ray abdomen finding of a surgical condition that I mentioned in my previous slide also. That would be sigmoid volvulus. Though we can do a CT abdomen in any abdominal emergency most of the time, in government hospitals we may not be having a CT available, so we might be doing an X-ray initially, and if facilities are available, we might be doing a barium enema for sigmoid volvulus, for which subsequently an endoscopic detorsion would be required. The main treatment for sigmoid volvulus would be a endoscopic detortion. The details of this can be read more from the surgical perspective. The subsequent case that I'm describing is of a female patient who's having dysphagia for both liquids and solids. She also says that I get a sensation of as if something is stuck in her throat all the time. And she's also complaining of chest pain, especially when she's trying to eat fast, or let me say she's taking a hot or a cold beverage. That's when the symptoms are being worsened of chest pain. Initially, I thought this patient could be having a cardiac problem because chest pain was mentioned, but then the other manifestations that are present in this patient point towards possibly a non-cardiac etiology of pain. In these patients, lots of time you might be initially doing a ECG and even a treadmill test to rule out the possibility of chronic stable angina, because even in chronic stable angina, patient might tell you that I have chest pain after eating food. That is postprandial angina. But in this case, the treadmill test was normal, ECG was normal, and that is when I decided to do a barium study in the patient as well, slash a esophageal manometry. And what I found on a barium swallow in this patient was this characteristic segmentations that you can see with respect to the flow of barium in the esophagus. So the condition that I'm describing before you is called as esophageal angina. Why we call it esophageal angina is because the esophagus will contract with so much of force that it will constrict its own blood supply. The blood supply of the esophagus is through its wall itself, and the contraction will squeeze the blood vessels traversing through it, which results in the chest pain manifestation. In fact, you will use two terms to describe this manifestation. One is called as nutcracker esophagus, and the second one would be called as diffuse esophageal spasm. Both of these terms do not mean the same, and I'll explain to you what are the fundamental differences between the two. The first and the foremost is that in achalasia cardia, you might read about aperistalsis, but in this case, it's a mayhem. The esophagus is not contracting in a synchronized fashion. Like when you and me eat a food bolus, the moment we take a food bolus in our oral cavity and we make a swallowing activity, within 10 seconds it reaches our stomach due to coordination of all the muscles. Now when the proximal part of the esophagus would be contracting, the distal part would be relaxing. That's how peristalsis moves. But in this particular case, there is a non-coordinated activity of the esophagus. So let's look at the barium swallow findings in this patient. One, I would like to make it very clear before you that barium swallow is not the investigational choice for diagnosis of diffuse esophageal spasm. The investigational choice would be answered as a high resolution manometry. But still, because in the exam they've given images related to this, so I would like to point it out. One term that you'll always read to describe this would be a corkscrew appearance, or I initially used the word not corkscrew, but I just said segmentations present all through. That's because of the non-coordinated contraction of the esophagus. In fact, the lower esophageal sphincter in this patient is contracting at the same time when the distal esophagus is contracting. You see, in you and me, the distal esophagus will contract, the lower esophageal sphincter will relax so that the food can go in the stomach. Now, if both will contract, the food is going to be stuck there only. That is why the patient was having this sensation of something stuck in our throat most of the time, because the upper part of the esophagus could also be having the same problem. The upper part is contracting, the middle part is not relaxing, so the food is stuck initially, and therefore corkscrew appearance or segmentation appearance is what I have shown here before you. Another term that they use in radiology to describe this is a rosary bead appearance. The investigational choice to confirm the diagnosis of this patient, though if the MCQ begins by chest pain, first you have to think cardiac cause of pain. This is a non-cardiac cause of chest pain in a patient. The IOC for this condition would be answered as a high resolution manometry. I'll show you the image of high resolution manometry before you, and it would be a riot of colors. Traditionally, let me just show you the image. I mean, first time when you look at it, no, it looks like some perfusion scan, or it looks like I would say initially when I saw this image when I was an undergraduate, I thought, something like maybe, I mean, it was not totally available in India at that point of time. So I thought maybe some special kind of a Doppler. But then a Doppler images are different. In this case, it's a riot of colors, I would say, with respect to the sphincter proximal and the distal esophagus. And the certain pressure curves also mentioned here. I'll not get into the interpretation of those pressure curves also. But the point is that when you do a high resolution manometry in these patients, you would be getting certain findings that would help you in confirming the diagnosis of this condition. There is a possibility that on esophageal manometry, the amplitude of contractions may be normal, but it may not be coordinated. It is uncoordinated activity. On the other hand, if the amplitude of contractions is increased, sometimes the pressure could be as high as 180 millimeter. You see, systolic blood pressure is 120, and I'm saying the esophagus is contracting with a force of 180. That would be even exceeding the systolic blood pressure, though for few seconds. But that explains that this extreme amount of pressure would be crushing the blood vessel, kinking the course of the vessel, and that explains the chest pain in this patient. So there are two terms that I would like to state at this particular point of time. One is nutcracker esophagus. Second is diffuse esophageal spasm. The main fundamental difference between the two is that in diffuse esophageal spasm, it's an uncoordinated activity. The amplitude of contractions can still be normal. That is, upper part and the middle part of the esophagus are contracting together. But if you have is increase in the amplitude of contraction itself to the level that it exceeds even the systolic perfusion pressure, then the term that we use for it is nutcracker, where I said pressure could go up to as much as 180 millimeter mercury for as long as about 6.5 seconds. Now, when it comes to the reports with respect to this manometry, this is what the textbook says. One of the features that could be present is that when you are gonna go in for the wet swallows in the patient, you will notice that almost 20% of these contractions might be occurring simultaneously, and the pressure would be more than 30 millimeter in the distal part of the esophagus, or they could be repeated contractions of the lower esophageal sphincter, and in some cases there might even be demonstration of aperistalsis. These are three diagnostic criteria. You don't need to remember. These are the findings of manometry that would help you with diagnosis of diffuse esophageal spasm. I don't expect you that they'll expect you to remember these percentages values that are given in the question. But if you read a question that begins by describing chest pain and then he talks about manometry findings like these, at least if you go through them once, that gives you capability to analyze the question and answer accordingly. For management of these patients initially, one of the drugs which has been shown to be highly efficacious, I mean, don't straight away answer nitrates for these patients. It is mainly anxiolytics which have been found to be useful. Why anxiolytics? Because you see, if somebody is having chest pain all the time, especially after eating food, he might think there's always something wrong with my heart, and the doctor is not able to make a diagnosis. So it becomes a little difficult for to you also to explain to a patient that this is a non-cardiac cause of chest pain, and anxiolytics would work here. And apart from this, we can be using nitrates as well. When it comes to nitrates, I would say that they can be disadvantage also, because nitrates can cause lowering of blood pressure also in the patient. So we have to give the lowest possible dose in these patients. Other drugs which have been used are calcium channel blocker, but as such, none of these drugs have been proven to be highly efficacious. It is just that there would be a relief of symptoms. Otherwise, it's a horrible disease to have. DES, the main aspect that has been asked in the exam is one, the barium swallow findings in the patient, and then the IUC for this condition, which happens to be a high resolution manometry.
Next, I'll be describing before you some important upper GI endoscopic findings which have been asked in the exam in the previous years. The first one is feline esophagus. This would be corrugated irregular appearance of the esophagus, and this would be found is eosinophilic esophagitis. Now, I know the controversy that would come up here will be that you will say that in some of the sources it is mentioned as one of the findings that is seen with the gastroesophageal reflux disease. So my point is that in Harrison, he has mentioned primarily eosinophilic esophagitis. He says that it is associated with GERD. In fact, this disease is even associated with asthma as well. You see, asthmatics, he has mentioned as an association. So it's okay. I mean, GRD and asthma are associations. The primary condition, which is where feline esophagus is found, is eosinophilic esophagitis. And to confirm the diagnosis of eosinophilic esophagitis, we would need a biopsy. And in biopsy, he says that there should be demonstration of more than 15 eosinophils. E here stands for eosinophils in the specimen that has been provided to the pathologist per high power field. The second and the third entries of endoscopy are asked as serpiginous ulcer and volcano ulcer. Now, serpiginous ulcer is what you read with Crohn's disease also. But Crohn's disease would be involving whole of the GI tract. Here I'm specifically talking about only serpiginous ulcer or ulcers located in the esophagus of the patient. This would be a patient who is immunocompromised. He might have undergone a solid organ transplantation, and then there could be an opportunistic infection coming up. That would be cytomegalovirus esophagitis. In contrast, another term that is used is a volcano ulcer. In this volcano ulcer, the cause would be answered as herpes simplex virus HSV esophagitis. Especially for serpiginous ulcer, I just want to say that if alone serpiginous ulcer word is given, then answer it as Crohn's disease. But if he specifies in the esophagus, and if he gives you a situation where the patient is immunocompromised, like after any kind of a hematopoietic stem cell transplantation or solid organ transplantation, then it is cytomegalovirus. The next condition is very interesting. Cerebelliform appearance of the stomach mucosa. You see, just like brain has gyre and sulci, the stomach mucosa has rugosities which are big, and those big rugosities would give a pseudo appearance of as if it's a brain surface. Now, this is going to be encountered with Menetrier's disease. In fact, Menetrier's disease is a pre-malignant condition. This can be associated with gastric ulcers as well. One of the important cells which exhibit a hyperplasia in this condition is foveolar cells. And foveolar cells produce mucus. On endoscopy, you will be having a very slimy, wet appearance of the stomach because of excessive mucus production. It will cause the light to reflect or shine off of the surface of the stomach mucosa, and the appearance of the stomach mucosa is called a cerebelliform, which would look like gyre and sulci of the brain. For Menetrier's disease, if they ask about the treatment part, do not talk about straight away a gastrectomy. Though obviously a surgeon will talk about gastrectomy, but that would be only to teach you regarding the subtypes of gastrectomy. In these patients, first we use a monoclonal antibody, that is cetuximab, for management. And at the same time, because he said it is pre-malignant condition, so because of the associated gastric ulcer. So when you read the list of pre-malignant conditions, cerebelliform appearance stomach mucosa, Menetrier's disease also comes up. Then is another interesting term, that is watermelon stomach. Now this would be a rare cause of upper GI bleeding, that is hematemesis. Just like you are aware that the most common cause of upper GI bleeding or hematemesis is peptic ulcer, one of the rarest causes of upper GI bleeding or hematemesis is a vascular problem of the stomach, that is gastric antral vascular ectasia, that is GAVE. This, when you read the table in textbook, one among the causes of hematemesis, this is given right at the bottom.
I'll just write the full form here also, gastric antral vascular ectasia. And because it's a vascular malformation, the reddish appearance is what is trying to give a semblance with respect to cut watermelon. And when it comes to cracked mud appearance or fissures or a mosaic pattern, there can be two possibilities. One, he could be just describing it with respect to the oral cavity. Then this would be with respect to leukoplakia. But if he says that the cracked mud appearance is being talked about with respect to duodenum, then there are two diseases which are to be considered. One is Crohn's disease. I agree that in Crohn's disease, we traditionally read about a cobblestone mucosa, but then I am currently describing a term that endoscopists would be using. And another disease of the duodenum where this can be encountered is celiac sprue, which is a cause of malabsorption syndrome, where we always read about anti-TTG antibody, that is anti-tissue transglutaminase antibody. Do not confuse with anti-ETG, that is anti-epidermal transglutaminase antibody, which is seen with dermatitis herpetiformis. I said TTG, tissue transglutaminase, versus ETG, that is epidermal transglutaminase for dermatitis herpetiformis, which is related to celiac sprue as well. So these are six important upper GI endoscopic findings that I have mentioned here before you. When we talk about the leading cause of peptic ulcer disease, it happens to be Helicobacter pylori. This would be type B gastritis, a urease positive organism causing ammonia production, which would be alkaline, and this will cause G cell stimulation, hypergastremia, and then excessive amount of acid also being produced. Then we read about Johnson classification, which would be used for gastric ulcer. How many types of gastric ulcers do we read? Is a total of five, and he's asking you which is the commonest one that you encounter. So that would be type 1 gastric ulcer. That would be in majority of cases. Another aspect of peptic ulcer disease that is always asked is a complication that can be seen, which is perforation peritonitis. One of the leading causes of perforation peritonitis happens to be PUD. And this X-ray is one which can be always missed in the exam. I'll give you fancy things like eventration of diaphragm and maybe even a diaphragmatic hernia. But then this is very hard to miss, gas under diaphragm. I would say this particular X-ray that I'm showing in the GI tract, when it comes to this particular X-ray, at least in FMG exam, this is almost every exam, there will either be an X-ray of intestinal obstruction, easy to pick up, step ladder pattern, small bowel obstruction he'll give you, or he's going to give you gas under diaphragm. In NEET PG, obviously, he might give you a more detailed history and then talk about some surgical aspects also. But then this is a straightforward scenario. The leading cause of intestinal obstruction can be adhesions and bands, and the leading cause of perforation peritonitis would be a gas under the diaphragm. Peptic ulcer disease happens to be the leading cause of development of hematemesis as well as melena. We classify melena as lower GI bleeding, but the number one cause of melena where you have a black tarry stool is peptic ulcer disease. So if he says what is the investigational choice for hematemesis, it is understandable, upper GI endoscopy. But even in melena, if he says what is the investigational choice, the answer would not be given as colonoscopy, but would be upper GI endoscopy, primarily because all the causes that we study, whether it be Mallory-Weill syndrome, or which is submucosal tear, or whether we read about peptic ulcer disease or portal hypertension or esophageal varices, they all would be identified with help of upper GI endoscopy. And peptic ulcer disease as a topic is covered in the surgery as well. So just cater to the primary issues which one should be remembering. We next move on to inflammatory bowel disease, where we'll talk about ulcerative colitis. And what I'll describe before you here is a new entry in the 21st edition of Harrison, where he has talked about a Montreal classification with respect to ulcerative colitis. So let's just dive a little deeper into this Montreal classification and see what is he trying to talk about. One is trying to talk about the extent of the disease. Like lots of time you would be having only the most common part of the gut that is involved in ulcerative colitis is the rectum. So in majority of patients, you would be having only proctitis. But once this patient is documented to be having proctitis after a proctoscopy, or let me say you did a full colonoscopy and only the proctitis component was documented, you'll write on the case file E1. On the other hand, if it is going to be involvement of mainly the left side of the colon, inferably from splenic flexure, Where I put the arrow is the splenic flexure of the patient. So from there downwards, right up to the sigmoid colon and the rectum is involved. So splenic flexure onwards and downwards is E2. Whereas if you have a pancolitis present, that is whole of the colon is involved in the patient, then the term used would be E3. Now let us compare this with part 2 of the Montreal classification, where he talks about the severity of the disease as well. For severity of the disease, earlier we used to use words like mild, moderate, and severe, and now is using terms like S1, S2, and S3. So let's look at when do you say that it is S1. Like lots of time you might be writing on the case file E1, S1. So E1 means proctitis and S1 means that there is passage of at least 4 or fewer stools per day with no systemic inflammatory findings present. ESR of the patient is normal at the moment. Now, suppose a patient is having 4 or more stools. The difference for mild and versus moderate would be stools once coming up that is less than 4 and more than 4. I mean, equal to or less than 4. And if it is going to be more than 4 stools per day, that is one difference. And along with that, you will also notice that there would be some additional findings of inflammation that would be present, which could be in the form of, let me say, elevated ESR in the patient. But another number you need to now remember is if the number of stools that is being passed in the patient is 6, and along with this, because there is a blood loss happening substantial amount on a daily basis, bloody diarrhea is one of the presentation of patients of ulcerative colitis. So this person would be having a tachycardia also coming up. The heart rate of this patient would be increased. Then body temperature can be increased in the patient. There could be low grade fever because he's losing blood. There would be anemia present or the ESR of the patient is elevated. All these are telling you regarding the, I would say, the systemic manifestations of the disease or the severity of the disease is relatively more. So there is a possibility that he might write down terms like E1, S1, which I said is proctitis with less than 4 stools passed per day. And then obviously you could be having a E2, E1, S2 component or a E1, S3 component as well. Once we have read about this Montreal classification, what we will do next is compare the manifestations of Crohn's versus that of ulcerative colitis. In Crohn's disease, the major part of the gut that would be involved will be the ileum. So a lot of time the patient might be having a stricture formation because in Crohn's disease along the gut and the whole of the gut is involved. There would be stricture formation along the entire length of the intestine. So when food will try to pass through this area, the intestine will contract with more force to push this food in a forward direction, which explains the fact that why colicky pain or abdominal pain is more common in Crohn's disease. I mean, these patients might be taking meftal-spas or antispasmodic tablets on a regular basis. And when it comes to patients of ulcerative colitis, there might be pain present, but this pain will be present just before the passage of a stool. And when he will go to the washroom, most of the time he will say, sir, there was hardly any fecal matter. I mean, I said word bloody diarrhea. So there might be discomfort noticed by the patient. Lots of time there may not be even pain also. So I'm saying it's not that pain will always be present in ulcerative colitis. Lots of time he will say, sir, it's literally when I go to the washroom, it's literally blood only coming. So painless bloody diarrhea could be a presentation or there might be a pain present. But the main highlight is stricture formation is one of the highlight of Crohn's disease. Whereas when it comes to ulcerative colitis, it is mainly rectum that is involved. Rectum is paired in Crohn's. Let me just jot it down. Ileum is the most common part of the gut involved, and rectum, which is the commonest part involved in ulcerative colitis, is paired. So either of the two can be remembered. Either you can just remember rectum is paired in Crohn's, or you can remember vice versa that the rectum is the commonest one involved in patients of ulcerative colitis. Ileocecal lump will be a presentation with respect to the left hand side, but ileocecal lump would not be seen by you in patients of ulcerative colitis. Then most of the time there could be complications like toxic megacolon occurring in the patient. There would be tachycardia coming up, and a lot of these patients will be having nutritional deficiencies also. In fact, both of these conditions are example of protein losing enteropathy. Because of this protein losing enteropathy, if you check the serum albumin of this patient, This would always be lesser. Hypoalbuminemia. So sometimes, especially in ulcerative colitis, because the amount of blood loss is pretty substantial, you might be noticing pedal edema coming in the patient as well. And along with blood, even though there would be nutritional loss also, so there could be anemias developing in these patients. And this anemia would not only be iron deficiency anemia, it could be dimorphic anemia because of vitamin B12 deficiency as well. Then there could be mouth ulcers in the patient for Crohn's disease, especially left hand side. Cobblestone mucosa is described, especially cobblestone buccal mucosa. If you read this word, or if you read this word, cobblestone buccal mucosa, that's a feature that is seen in Crohn's disease. I mean, because Crohn's can involve whole of the gut now, so the oral cavity in the patient can also be involved. As far as the complications are concerned, mainly patients of Crohn's disease would be having a presence of perianal fistula. So these patients would always be having bad smell coming from their undergarments, and sometimes if it's a high type of rectal fistula, there might even be fecal matter that might be staining the undergarments of this patient. At least a foul discharge will always be present. So most patients with Crohn's disease would be having a low self-esteem, because you see, when the bad smell is coming from the patient, he might initially feel bad about it, but then he might get used to the smell. And it's his family members who will always say that, oh, there's always bad smell coming from you. So I said a low self-esteem present in these patients. And apart from this, when it comes to fissures is again a feature. Perianal disease complication, perianal fissures is always a feature that is encountered in patients of Crohn's disease primarily. For management of Crohn's disease, we will be mainly using steroids. If he just says what is the drug of choice for management of Crohn's disease, it is steroids. When he says ulcerative colitis, now ulcerative colitis, we'll obviously be using sulfasalazine, so that is okay. But lots of time in the exam, he might actually just use the word ulcerative colitis exacerbation. Like, this is a young student, he's having an exam and following just when the exam is 1 day away or 2 days away, he's having worsening of his symptoms. So for exacerbation, we will again be using steroids, and this time we'll be using budesonide enemas in these patients to reduce the proctitis component that would be present. As you know from basic pathology, you would be having non-caseating granulomas. Whenever you read about Crohn's disease is always written as granulomatous colitis. And when I say non-granulomatous colitis, it's gonna be ulcerative colitis. The corresponding term that you need to remember for ulcerative colitis is cryptopsis. Yes, you could be having cryptopsis written even in the literature of Crohn's disease in some of the books. But if they give you a question, then for cryptopsis, the primary answer would be given as ulcerative colitis, and the features of the disease might be having a some amount of overlap. Crohn's disease is a full thickness disease. All the layers of the intestine would be involved, whereas when it comes to ulcerative colitis, it's limited to only the mucosa and the submucosa. And for the right hand side, toxic megacolon would be relatively more common. Toxic megacolon definition is where when you are gonna do a X-ray study, then the total diameter of the colon would be more than 6 centimeter. Or the total diameter can be measured radiologically by the radiologist, that would turn out to be more than 6 centimeter diameter. Then we can have extraintestinal manifestations. And before I go to the extraintestinal manifestations, I want to tell you that cancer can be seen in both of them. Both of them are pre-malignant conditions. The risk of cancer is present in both of them. In some books, initially it was present that ulcerative colitis risk of cancer is more than that of Crohn's disease, as you can see in the current data also. But in the current edition of the textbook, he says that the risk is almost equal. So don't focus on the percentage values here. Just you need to remember both are pre-malignant, and in both of them the cancer risk would be present, and it's very, very little difference present. So most textbooks nowadays mention that the risk of cancer in the patient is equal for both ulcerative colitis and Crohn's disease. Then would be some radiological terms which are asked for barium meal follow through, which would be done in these patients. The term string sign of Cantor. If I say string sign of Cantor, that is easy for you to answer as Crohn's disease. But usually I find errors with respect to what I'm saying next. That is going to be lead pipe colon and a hose pipe colon. When you will Google this, you will notice that in some of websites like Radiopedia, they are mentioning hose pipe and lead pipe is same, but that is not the case, because I'm sure, a lot of time I get queries why people just Google finding, and they say, sir, this is given in both, lead pipe and hose pipe is given to be the same. But in some of the classical textbooks, the terms are given to be different. Now, I know that this will cause a bit of discomfort on your part to say, sir, both are pipes. So, what is the examiner trying to achieve here by asking it? But this was a question, I think, in the UPSC exam, because of which the combined medical services exam, because a couple of students sent me across this, that lead pipe colon, that's relatively easy for you to answer, that is ulcerative colitis. But if he says the word hose pipe colon, that should be answered as Crohn's disease. String sign of Cantor is relatively easier to pick up. However, this lead pipe colon on the right hand side is a late feature. If he says earliest feature to develop, that would be mucosal granularity. You see, in ulcerative colitis, initial presentation, I mean, you would not straight away have, because the disease starts not from the outside, it starts from the inside. So this lead pipe colon is a relatively a late manifestation in the patient. And nowadays, anyway, we don't use a barium meal studies for this patient. We will be using endoscopy, and apart from we have a capsule endoscopy, and apart from capsule endoscopy, we can also go for CT enterography in these patients. If he says, how do you identify whether it is Crohn's or ulcerative colitis? I said there are two ways to differentiate between the two. One is capsule endoscopy, and apart from this, I can be doing a CT angiography in the patient as well. So combination of the two findings, or a combination of the two, because from medicine perspective, it's not that only in radiology that they're saying that the best way is CT, because radiologists will mainly be doing a CT. Interventional guy in gastroenterology unit will be doing an endoscopy. In Harrison, it is first mentioned endoscopy findings for the workup of the patient. There's nothing like investigation of choice. He's saying endoscopy is sufficient for diagnosis. You have to do in Crohn's both upper GI endoscopy and colonoscopy. And you can also do a capsule endoscopy also. Technology being used to your advantage. And along with that, a CT angiography would be welcome as a non-invasive method for identification of differentiation between Crohn's versus ulcerative colitis. And now comes a very shocking slide. Shocking in a sense that the most common extra-intestinal manifestation of IBD, which was given in the older edition of the books and the current one, is different. In the 20th edition of Harrison, he was totally silent about how many percentage of patients would be ending up with development of metabolic bone disease. He did talk about osteoporosis and osteonecrosis. Osteonecrosis because you're using steroids now, so avascular necrosis will occur. But he was silent regarding the percentage of patients who would be developing it. So in the older edition, you used to read arthritis is one of the leading extra-intestinal manifestations. But in the current textbook, in the current 21st edition of Harrison, is given a table. In that table, he has given percentages, which I'm currently sharing with you. So if he asks you to answer as the number one extra-intestinal manifestation, the update from the 21st edition of Harrison would be given as metabolic bone disorder, followed by hepatobiliary complications. Earlier it was arthritis followed by hepatobiliary. Now it's metabolic bone disorder followed by uh, hepatobiliary. That would be in 10 to 35% of the cases. And why I'm giving you figures is because Harrison has mentioned that in a tabular format. He never mentioned percentages in the previous edition. It could be fatty liver, it could be cholelithiasis or primary sclerosing cholangitis. Yes, the same condition where we read about association with P-ANCA, though we read about P-ANCA with microscopic polyangiitis as well. Then is the standard rheumatological joint involvement. You could be having peripheral arthritis. This peripheral arthritis will be asymmetrical. It would be possibly that like you get in rheumatic fever, no, or migratory polyarthritis, maybe only one knee joint or one side is involved, and then subsequently the swelling might appear in the contralateral ankle joint of the patient. So like the kind of monoarthritis and a migratory polyarthritis that you read with patients of rheumatic could be present in these patients as well. Then could be sacroiliitis and ankylosing spondylitis like features. And a lot of patients of inflammatory bowel disease, especially ulcerative colitis patients, could be HLA-B27 positive. So we read about HLA-B27 positivity in juvenile rheumatoid arthritis, then in ulcerative colitis slash inflammatory bowel disease, and obviously in ankylosing spondylitis and Reiter syndrome as well. Urological complications could be present in these patients also. They could be renal stones, and especially in Crohn's disease, after we do a small bowel resection, there is a higher incidence of calcium oxalate kidney stones in these patients. This is itself a question in Crohn's disease patient after small bowel resection. One of the complications seen is what kind of stones. So your answer would be given as calcium oxalate stones. Then could be skin lesions in the patient, which could be in the form of erythema nodosum. Though you read about erythema nodosum even in patients of sarcoidosis, these are lesions on the shin of the patient, but they are not going to ulcerate. If you have an ulcerative lesion on the shin, you see erythema nodosum would be a purplish, shiny, painful lesion on shin of a sarcoidosis patient slash IBD. But if you are having an ulcerative lesion, then it would be pyoderma gangrenosum. He is gonna give you a description that a IBD patient on the shin is having a ulcerative lesion. That would be pyoderma gangrenosum, and ocular manifestations can also be present. So this is, I would say, update from the 21st edition of Harrison for the extraintestinal manifestations of IBD that I would like you to remember. Next up is the topic of malabsorption syndrome, where they usually ask about celiac sprue. The cereals which would not be given to these patients would be mainly barley, rye, oats, and wheat. And what can be given in these patients is one maize. In fact, in poor patients in a country, we may even use rice. So rice might be having some amount of gluten. And then another expensive one which can be given in these patients and was asked in the FMG exam is quinoa. Celiac flu is characterized by autoantibodies. These antibodies would be damaging mainly the microvilli of the intestine. Now, microvilli will be responsible for absorption. If you decrease the surface area which is available for absorption, then sugar will not be absorbed. This is going to contribute to development of osmotic diarrhea. So this condition contributes to mainly failure to thrive. The question will begin with a description of a child who's older than 6 months of age. You see, before 6 months of age, this child was exclusively breastfed, so the growth was perfect. But after 6 months, from the day the mother has started complementary feeding, complementary feeding, you continue with breastfeeding and you add cereals because they calorie dense. With this mother is blaming you as a doctor. She says, doctor, since I followed your advice and I started giving cereals to my child, that is when there is failure to gain weight and he tends to have loose motions as well. So you would tell her that your child is having antibodies which are causing a problem here. The antibodies which are present here are called as anti-tissue transglutaminase antibody. Another antibody that can be given in the MCQs is anti-epidermal transglutaminase antibody, that is anti-ETG. And this is what we encountered with the skin manifestation that is seen with patients of celiac flu in future, that is dermatitis herpetiformis, for which you study dapsone happens to be the drug of choice. In patients of celiac flu, it is autoimmune damage which is responsible for the trouble. And the best way to confirm the diagnosis of this condition is a small intestinal mucosal biopsy. In fact, this biopsy might have to be repeated twice. Initially, what you will do is at case presentation, you will do a biopsy that will show villus atrophy, and then you will go in for strict gluten elimination from the diet. And about 4 to 6 weeks later, when you repeat the biopsy, there will be regeneration of the villi. So the comparison of the two biopsy span samples before and after gluten restriction would be the surest way to confirm the diagnosis of these patients. And is also asked that what is the leading cause of death for patients of celiac flu. So do not answer malnutrition or anemia as the leading, or infections as the leading cause of death. In fact, in these patients, the leading cause of death would be cancer, malignancy. A lot of these patients of celiac flu can, I'm saying not always, but can end up with development of lymphoma of the gut. So even if you are having improvement in the condition of these patients post gluten restriction, they should always be in a follow-up because of these complications of dermatitis herpetiformis, and follow-up for possibility of development of gut malignancy as well. That would be lymphoma of the gut. The proximal part of the intestine is the one which is majorly affected in this condition. It's the duodenum that is affected more, which also explains the fact that why iron deficiency is primarily present in these patients, but vitamin B12 deficiency is usually not present because ileum is usually spared. In the order of involvement is duodenum is max involved, followed by jejunum, and ileum involvement is usually not found. Now we compare this with the second cause of malabsorption, that is Whipple's disease, where again we will have to go in for a small intestinal mucosal biopsy, and that will show past positive inclusions. Well, what are these past positive inclusions? That would be bacteria The name of the bacteria is Trophaerma vipili. When we read the name the first time, the impression is it's something like a fungus, but it's actually a intracellular bacteria. Helicobacter pylori is an extracellular bacteria, but this Trophaerma vipili is an intracellular bacteria, and this is responsible for these past positive inclusions that can be seen. Then you will also notice that small intestinal mucosal biopsy is the best way to confirm the diagnosis of malabsorption syndrome. But one condition where you will not answer small intestinal mucosal biopsy is currently on the slide, that is presence of bacterial overgrowth. Now, when you read the word bacterial overgrowth in literal sense, it means growth of more bacteria in the intestine. But what is happening in bacterial overgrowth syndrome is that large intestinal bacteria are migrating via an incompetent ileocecal valve into the small bowel. Small bowel would be having very minimal bacteria mainly present in the large intestine, and there's a door which is ileocecal valve, which is a one-way valve which prevents the bacteria from coming into the small intestine. But in small intestinal, or I would say for primarily diagnosis of this condition, if he says how would you confirm the diagnosis, instead of answering a mucosal biopsy, you will say that you would access the small intestine, that is jejunum, and you will take up jejunal aspiration, jejunal aspirate, and then you will do a culture. And if this culture is showing bacterial counts which are to the rate, I would say to the value of 10 raised to power 11. Now, these kind of counts are what are encountered in the large bowel. If in the small bowel, the counts that are being obtained are almost identical to that of the large bowel, that is when we say bacterial overgrowth syndrome. And as I explained here, it does not literally mean that there is overgrowth of bacteria. It is actually large intestinal bacteria that are migrated to the small intestine of the patient. And in these patients, antibiotics would cause a temporary relief. So metronidazole would be used, and mainly the part of the gut involved in bacterial overgrowth syndrome will be ileum. So vitamin B12 deficiency will be more common in this condition. In contrast with celiac sprue, where I was saying jejunum, duodenum and jejunum are involved, so you can have iron and a folic acid deficiency relatively, but not B12. But in bacterial overgrowth syndrome, it will be an abnormal Schilling's test, and that would get normalized with administration of antibiotics. Now, Schilling's test is again a question which is usually talked about in physiology. What I'm going to do next is give you some permutation combinations with respect to D-xylose absorption test. Xylose is a pentose sugar. Xylose happens to be a pentose sugar, and this pentose sugar can be absorbed directly via the bowel wall or small intestinal bowel wall, primarily by the microvilli. You see, hexose sugars need to be broken down, but pentose sugar can be absorbed directly. So basically, D-xylose test is helping me evaluate the status of the mucosa. I mean, it's going to tell me whether the mucosa is healthy or unhealthy. And in patients who are having, let me say, celiac sprue, then the small intestinal mucosa is defective. I mean, the duodenal mucosa, the jejunal mucosa is defective. So you will always notice that in patients of celiac sprue, the D-xylose absorption test would be showing a decreased absorption, obviously because the mucosa is damaged. But that would not happen with respect to chronic pancreatitis or bacterial overgrowth syndrome, because in bacterial overgrowth, it's mainly going to be ileum that is going to be involved. If some part of jejunum is involved, then you can see that the textbook says that it can be modestly abnormal. Most of the time it's normal, modestly abnormal if the jejunum gets involved in the patient. So when you are gonna do these battery of tests, that is D-xylose absorption, Schilling's test, and duodenal mucosal biopsy, you can make a diagnosis. Please remember that for absorption of vitamin B12, you also require pancreatic enzymes. You see, for B12, we very well know one requirement is the intrinsic factor, and second is going to be a normal mucosa of the terminal ileum. But in between the stomach mucosa, which is producing intrinsic factor, and the terminal ileum, which is the site of absorption, where intrinsic factor will facilitate vitamin B12 absorption, is pancreatic enzymes as well. So in patients who are having chronic pancreatitis, because pancreatic enzymes would be lesser, therefore the ability of the body to assimilate B12 will be hampered. Pancreatic enzymes play a role in helping in absorption vitamin B12 from the terminal ileum. If they're not present, you will notice the Schilling's test can be abnormal but will become normal with pancreatic supplements. So if you look at the first entry, chronic pancreatitis, there is no problem with the mucosa. So these patients of chronic pancreatitis will also come with steatorrhea, no? I mean, if you're wondering why am I discussing this topic, malabsorption syndrome would be having osmotic diarrhea and steatoria. So I have a patient with greasy, bulky stools, and he's an undiagnosed case of chronic pancreatitis. I obviously can do a contrast and a CT in these patients for diagnosis of chronic pancreatitis, but to identify the steatoria, to document that yes, the steatoria is primarily due to chronic pancreatitis, the D-xylose absorption test would be normal, no problems with the gut mucosa per se. Dural mucosal biopsy will obviously be normal, but Schilling's test would be abnormal and will become normal with pancreatic enzymes. So if you read a question where Schilling's test is becoming normalized with antibiotic administration, then you will think in terms of bacterial overgrowth syndrome. In this condition, as I said, it's the ileum and the jejunum getting involved. So you may have a problem with D-xylose absorption also. You saw a normal report of D-xylose, a abnormal report of Schilling's test in the first entry in the table. But in the second one, what you're noticing is that even D-xylose can be abnormal and Schilling's test will also be abnormal. Both will be given abnormal, but normalization will be seen with administration of antibiotics. If we compare the fourth entry here, celiac screw, which will be the easiest one to identify, if he gives you antibodies, if he give you findings of flat microvilli and villus blunting written, I mean, the diagnosis would be made anyway, and you don't need to focus on Schilling's test in that case, because as I told you, in celiac screw, it's mainly the duodenum and the jejunum that is involved. The terminal ileum would not be affected, and therefore B12 absorption will occur normally, which explains why that in this entry, Schilling's test is given to be normal. Then there's a possibility that everything is normal, still there is a steatoria. But the biopsy will give you evidence because you are having dilated lymphatics present. So there's a problem with the fat absorption. The condition that is mentioned is intestinal lymphangiectasia. In this entire table, the most important entry is the last one, where you will notice a normal report of D-xylose. So it's not a mucosal disease. Schilling's test is also normal. So terminal ileum is also fine. But still you're reading about steatoria. Steatoria is seen in pancreatitis. It can be seen in bacterial overgrowth. So in these patients, then the small intestinal mucosal biopsy report will come to rescue and would help you identify this particular condition. The subsequent topic that I'm going to explain to you is pseudomembranous colitis. Now, one of the reasons why it would be occurring is due to overgrowth of Clostridium difficile. And well, why would Clostridium difficile be producing toxin A, toxin B and causing this problem? Then it could be due to usage of antibiotics. Either this patient was put on cephalosporins for too long a duration, or it was clindamycin. In the MCQ, if they say which antibiotic is incriminated, both of these are incriminated, but first answer would be given as cephalosporins. And he can also give a histopathological image, the kind which is shown here. One, if you look at the appearance, you can pick up the architectural orientation of the gut, and then you can also see some glands in the gut as well. And this that you can see is like a volcano eruption. Like, yeah, when a volcano will erupt, there will be cloud present. So I'll just use an unofficial term here. This is the pseudomembrane which is present. So I mean, this is a non-medical term. This is just to explain the pseudomembrane which has been shown in this particular slide, the volcano-like eruption of inflammatory material or inflammatory exudate which is present here. Though the diagnosis of this condition can be done even with colonoscopy, where these pseudomembranes would be present in the bowel of the gut, but that would be, I would say, very late manifestation. For early diagnosis of this patient, we have a couple of tests available. So let's look at the sensitivity and the specificity of these tests. The best way for diagnosis of pseudomembranous colitis is a stool culture. But then the textbook says that stool culture, though it is both sensitive as well as specific, let's look at what the textbook says. He says that this is overall the most sensitive test, but it is not practical because the turnaround time of the stool culture report will be too slow for practical usages. So therefore, what test would be having a comparable sensitivity and the specificity? I had to show this table, guys, to you, because otherwise if I say that, okay, this test is more accurate as compared to the previous one, it would not make sense. But you can see a couple of, plus signs present here, 4 plus signs, which are talking about implying more than 90% sensitivity. Another test which is giving a comparable accuracy for diagnosis and would be answered by you in the exam is nucleic acid amplification technology, a NAT, for Clostridium difficile toxin A or B gene present in the stool. You need to remember the complete thing. NAT for Clostridium difficile toxin producing toxin A and toxin B, the two of them producing gene in the stool, is the best way for identification after stool culture. As I said, colonoscopy, sigmoidoscopy will also help. They're highly specific, but that would be only when the pseudomembranes are fully developed. No, in the early part of the disease, it is NAT which would be used. Now, suppose NAT is not present, then what are other tests that you could be using in these patients is EIA. That would be enzyme immunoassay for Clostridium difficile common antigen. You can see that even superiorly it is written enzyme immunoassay for toxins A and B in the stool of the patient. So there would be two terms. One is enzyme immunoassay for toxin A and B. Second would be enzyme immunoassay for Clostridium difficile common antigen in the stool. So if you come across both of these terms, then you have to give more credibility to the one that I mentioned. Now, I'll not rather bother you by putting more number of stars everywhere, but this is the order that you'll answer in the exam. Stool culture will usually not be given because that's anyway best way for identification. The turnaround time is slow. So I said most MCQs will talk about NAT, enzyme EIA. EIA coming up two times, enzyme immunoassay. For one, he will say toxin A, toxin B. Second time, he will say common antigen in the stool. And you can see the sensitivity of this test is turning out to be slightly more. I mean, 4 plus given as compared to 3 plus. So that's how you need to remember the data for diagnosis of this condition. And now we will come to the more controversial issue, that what is the drug of choice for this condition. So I know that you will say, sir, we have read it is fidaxomicin. Agreed, fidaxomicin is useful for initial episode, but not for severe. This is a table from Harrison. Why I'm showing this is primarily because I want to put rest to this controversy. The textbook doesn't say drug of choice. He just says that if it's going to be an initial episode or if it's going to be a first recurrence, then fidaxomicin would be used. But for all subsequent discussions, whether he's saying severe presentation, fulminant presentation, or he says multiple recurrences, 3 times he has mentioned in the table vancomycin. So there's no clear-cut winner in this case. I would say in the table, if you look at the data, 3 times it is still vancomycin followed by fidaxomicin, and 2 times you can notice fidaxomicin coming up. So when would you answer fidaxomicin as the DOC? Only when he says initial episode mild to moderate or he says first recurrence. I repeat once again, either the word first will come up. I mean, either the word first recurrence, that's why F fidaxomicin, or initial episode, that is mild to moderate. If it's going to be a severe presentation in the patient, systemic features present, tachycardia present, fever present in a patient, then for the severe, the fulminant variety where the gut would dilate also, and you might be having, I mean, patient may not be able to take orally as well, we will be giving vancomycin. And this is not intravenous, it is oral. Intravenous does not work in this case. Lots of time in our hospitals, I mean in India, I'll say lots of time oral vancomycin is not available, so we might have to give oral metronidazole to these patients. So you would have yourself given metronidazole sometimes to patients who are having diarrhea after administration of antibiotics like cephalosporins. But the usage of metronidazole is not very effective. It is two drugs, mainly vancomycin and fidaxomicin, which will be useful for management of these patients. And I hope this table gives rest to this controversy. What should be answered? I mean, depending on the terminologies described in the question, the answer would be given proportional to this. And you can also see in the table that if he mentions about recurrent Clostridium difficile infection where patient has already been given antibiotics and still the person is having a recurrence, then monoclonal antibody, the list of monoclonal antibody grows again here, that is basilotocumab can be used. So for Clostridium difficile infection, I decided to show these tables from the textbook to lay rest to any kind of controversies about what should be answered. Colonoscopy, sigmoidoscopy, as you can see, are very good ways. He says very highly specific. There's 4 plus for specificity, but he says only if the pseudomembranes are present. I mean, if they're visible, then the gastroenterologist will be able to make a diagnosis. If not, then you need to do a stool test in the patient, and what you check for in the stool is the gene. If gene is not present, then it is the toxin. Or it would be the common antigen. First is common antigen followed by toxin A and toxin B. That's the sequence which is to be remembered. And in this particular slide, I would rate this information that I explained to you as the most important one to be remembered. In fact, this is very easily forgotten by people. So, I mean, you can note it down somewhere, this information, so that because in both of them, EIA is given, no? So there are chances that you might forget it. I said the Clostridium difficile toxin antigen to be given preference over toxin A and toxin B. And gene is to be given a priority over and above both of these. Next up, I'll talk about aspects related to hematology that is covered even in pathology. So you are very good with this topic, but I'll just tell you a couple of updates. One of the updates from the current edition of Harrison 21st edition is, and this is stark contrast to what the 20th edition was saying. In 20th edition, it was mentioned that leading cause of death after blood transfusion. You see, don't answer mismatched blood transfusion because we take good care, right? We don't allow that due to internal quality control practices. Mismatched blood transfusion would be highly unlikely in era of computers. You have barcodes available. Very unlikely that a patient would receive a wrongly typed matched blood. So the leading cause of death after blood transfusion is TACO, that is transfusion associated circulatory overload. This will cause pulmonary edema, and because it will cause cardiogenic pulmonary edema, so values of BNP will be elevated. That is B type natriuretic peptide. Because there is volume overload, then blood pressure will also be elevated. Pulmonary edema will be a common finding between both of them. Both point number 1 as well as point number 2 will be having a presence of pulmonary edema. You see, in TACO, it is circulatory overload, so there will be more pressure, hydrostatic pressure in the blood vessels of the lungs. That increased pressure in the blood vessels of the lungs would cause a cardiogenic pulmonary edema. But when it comes to TRALI, that is transfusion related acute lung injury, this would be a non-cardiogenic pulmonary edema occurring in the patient. In these patients, because it is non-cardiogenic, so therefore BNP levels will be normal and blood pressure of the patient will also be towards normal. It could be lesser, it could be normal, depending on antecedental complications that would be present in a patient. But the message I just want to give to you is that if he says which of the following is the leading reason for death, then in the 20th edition, it was mentioned trolley, but in the 21st edition, on the current review of data, he has mentioned that TACO is the leading cause of death after blood transfusion. It might look very surprising to you initially, but this is how things are in our field, guys. I mean, in 2 editions of the textbook, stark change in data. Medical science, I know this causes distress also, sir. We read in the previous edition like this, and previous book used to say like this. I do get messages like that. But then the point is, medical science is a continuously evolving science. We continue to go through the data again and again, and we see where are we going wrong, where are we going correct, and what are the important causes of mortality, and what can be done to prevent it also. Like in TACO, you can understand, if you're going to give transfusion faster, 1 unit should go over 4 hours. If you're going to give 2 units in 4 hours, you could have, instead of advantage, a disadvantage in the form of a transfusion associated circulatory overload in a patient. So TRALI now occupies the second spot with respect to non-cardiogenic pulmonary edema, and TRALI can be occurring with the whole blood transfusion as well as with fresh frozen plasma. And if he says what is overall the most common complication of blood transfusion, the answer is fever. That is febrile non-hemolytic transfusion reaction is the leading complication after blood transfusion. Then we always put a buffer. The buffers are like ACD, CPD, CPDA buffer. One of the common entries is citrate. And why do you put citrate? Because it will bind to calcium and it will prevent the blood from clotting. So one of the primary reasons why we put citrate is to prevent the blood from clotting. But if a technician who's not trained enough, like lots of time technicians might be doing this course after 10th class or 12th class, and they might be doing it from not a very good institute. So if they're not trained enough and there are quality control issues, then citrate excess could be present in unit of blood. Now, if you put too much of citrate, what will happen is that this citrate will be metabolized by the liver. All the citrate that goes into the liver will cause production of bicarbonate, and this is going to explain the metabolic alkalosis that develops in these patients. Apart from this, there will also be another problem. This will bind to ionized calcium, because citrate will bind to the ionized calcium. Therefore, the values of ionized calcium will begin to fall, and this can trigger carpopedal spasm and can cause tetany in the patient. So 2 important complications that can be seen with blood transfusion, even if quality control is maintained and there is no problems with mismatched blood transfusion, no trolley, no TACO, still, because of excessive citrate in the unit, there could be alkalosis and tetany in the patient. Then both hypo and hyperkalemia can occur. And the query of most people is, sir, will they occur in the same patient? No, no, no. I'm not saying that a single patient will be having hyper or hypo. One patient of blood transfusion could be having hyper, another could be having hypokalemia. Let's look at the reasons why potassium is spiking. You are all aware of sodium potassium pump. Function of sodium potassium pump will be to send potassium inside the RBC. Now, when there is going to be blood that is near expiry, You see, the storage time, the time that you store the blood in a blood bank is limited. That's why you put in a buffer. Like, most of the time with the, let me say, CPD buffer, the shelf life of blood would be about 35 days. With Sagam, it can go up to 42 days. The point is, if a patient is being given near expiry blood, then the problem is that the sugar supply in that unit of blood is getting exhausted. And if energy to the RBC's supply is getting exhausted, the sodium potassium pump will shut down. I repeat once again, when you look at the buffers, no, they're having some source of energy for the RBCs to live. You store blood at 4 degrees Celsius in the refrigerator, so RBCs are requiring some source of nutrition. Because the sources of nutrition in the buffer are getting exhausted, the sodium potassium pump will shut down, and because of which the potassium will not go inside, and once it does not go inside, there can be a hyperkalemia in the patient. So some patients can develop hyperkalemia, especially with near expiry date blood. In contrast, let us say a patient received blood transfusion and is having metabolic alkalosis. Now, there's a basic rule that I've always mentioned in the main videos, that pH is always inversely related to potassium values. Like in case of diabetic ketoacidosis at presentation, pH is less, potassium is high. Vice versa, if there is a metabolic alkalosis, then pH of the patient is high, more than 7.45, and potassium would be less. So hypokalemia in these patients is due to this basic rule of physiology, that pH and potassium always go the other way. What I mean by other way is both of them have an inverse relation. So in majority of cases, you would be having, if a metabolic alkalosis, then it's gonna be hypokalemia. But if it's a near expiry date blood being given to a patient, then the shutting down of the sodium potassium pumps would explain potassium not getting pumped inside, and the value of potassium would spike. And these are very frequently asked aspects: metabolic alkalosis, tetany, and both hyper and hypokalemia seen with blood transfusion are some of the very common questions that you will encounter. Now we will talk about some hematological malignancies here, and the most common leukemia in adult population is chronic lymphocytic leukemia. This is obviously more common in geriatric population, but just like you are comfortable with ALL be common in pediatric age group, CLL is overall the most common leukemia. And this simple question was asked in FMG exam. Everybody answered CML. I don't know the reason for that. You see, CML, we understand Philadelphia chromosome and massive sphenomegaly and blast crisis, extended phase. I mean, all those things you study. So because of all those fancy terms, the impression that comes in our mind is that, okay, CML is common. It's not the case. It is CLL, which is the commonest leukemia in adults. The age group of the patient would be around about 70 years of age, and initially the symptoms that are present might be identical to symptoms of even tuberculosis. You could be having fatigue, weight loss, night sweats in a patient, and there's a cervical lymphadenopathy developing in the patient. The term that we use for this symptoms, which are described in point number 1 and 2, is category B symptoms. Traditionally, you read about category B symptoms with Hodgkin's lymphoma. You see, when you read the classification for Hodgkin's lymphoma, he also mentions category A, category B. Category B means presence of whatever is written here, which is identical to TB. Category A means none of these are present. So initially, CLL patient would be a geriatric age group patient who's having non-specific symptoms, night sweats, low-grade fever, and enlarged cervical lymph nodes. Then he may be hospitalized also due to recurrent episodes of pneumonia, and there could be reactivation of chickenpox virus in his body causing herpes zoster in a dermatomal distribution. Lots of time there may be image-based questions where they might give grouped vesicles in dermatomal distribution on the chest of the patient across the course of the intercostobrachial nerve. Now, if you read about grouped vesicles on the genitals, that could be a presentation of herpes simplex. But if you read about grouped vesicles in a dermatomal distribution, like it could be on the face also, right? On the face also, then it is herpes zoster reactivation. And why that is happening is because in chronic lymphocytic leukemia, we have immuno-incompetent cells. It is immuno-incompetent B cells. One, because they are incompetent, they will not be able to fight against the infection. It's a clonal proliferation of immuno-incompetent B cells. And this is a pure B cell tumor, guys, and because they are incompetent, they might even produce, they may not be able to differentiate between self and non-self. So imagine the B cells here are producing antibodies subsequently, which are attacking self RBCs, and you will read about AIHA, that is autoimmune hemolytic anemia in these patients, which explains the fact that when I will show you the peripheral smear of this condition, there would be presence of spherocytes. This chap who's having cervical lymphadenopathy is now having infections also, incompetent cells, explaining that the incompetent cells are attacking self RBCs, and to add insult to injury, to add fuel to the fire, they are also attacking cell platelets. So this same chap could be having petechiae on his ankles, or he could be having purpuras, which could be, I would say, reddish, bluish in color or purplish in color over the extremities of these patients. And he might, the patient may not, I mean, pick up these technical terms, but he might just say that I am having some bleeding in my skin, doctor, can you have a look? And mostly you would find these initially on the lower extremities of the patient. Then organomegaly is anyway a feature in all blood cancers, so hepatosplenomegaly will develop, but these manifestations take time to develop. So a lot of time these patients can be misdiagnosed with even tuberculosis, and may remain undiagnosed as isolated visits to the hospital for maybe one for herpes zoster reactivation in 2020, and then a pneumonia episode in 21 and 22. So when you put the whole story together, when you look at the file right from the beginning to the end, and you are evaluating all these facts together, you find that this is the hematological malignancy, and peripheral smear will usually be given in the question, in which you will be able to pick up the smudge cells. Because these are immuno-incompetent cells, and they're also relatively, I would say, fragile. So when you are making a slide, these B cells would break up relatively easy. So one, you can look at this B cell. Why I'm calling it a B cell is because okay, let me just draw it down. I mean, for a B cell, I can say the nucleus is so big that it almost covers whole of the cell, and the cytoplasm is pushed to the periphery. So you can see two lymphocytes in this particular image with the cytoplasm almost pushed to the periphery, and wherever the arrows are, that is the smudge cells. Where during the slide preparation there has been a destruction of these relatively fragile cells. Then CBC of this patient will be showing a decrease in HB and the platelets, which is autoimmune in etiology. The peripheral smear finding of spherocytosis is what I've already said. So in a pediatrics MCQ, you will read about spherocytes with the hereditary spherocytosis, but in an old person, that is CLL, there's an autoimmune hemolytic anemia component, so you will have to do a flow cytometry. A recent question said, what is the best way for diagnosis? Do not answer bone marrow aspiration. Do not answer a bone marrow biopsy. Do not answer a excision biopsy of the lymph nodes. You do a lymph node biopsy in lymphomas. But for CLL to be diagnosed in a patient, you need to do a flow cytometry, where you will be predominantly having B cell markers, but there will be a T cell marker expressed on the cell. When you read about this, you will read CD19, CD20 DIM positive, CD23, and then CD5, which is a T cell marker being expressed on a B cell. No, because this is a I would say a tumor cell, a cancer cell. So it is doing the wrong thing, that it is expressing a T cell marker as well. Now, how do you differentiate this from a mantle cell lymphoma? For that, you'll have to go to the main videos. At the moment, I'm focusing on CLL primarily. And once the diagnosis is made on the basis of flow cytometry on the blood sample, I don't need to go in for a bone marrow aspiration in this case and then do a flow cytometry. Flow cytometry on the peripheral blood itself would help me pick up the cancer cells present in the circulation. Now, once the diagnosis is made, we need to treat it. And for treatment of these patients, in the older edition of the book, we used to read about PCR, that is pentostatin, cyclophosphamide, and rituximab. So these are two common drugs. Cyclophosphamide and rituximab are common. In older edition, we used to read PCR with pentostatin. We always used to do that MCQ, which of the following is actually not a statin. We're not a HMG coenzyme reductase inhibitor. It is pentostatin, which is used in CLL. But the current textbook mentions mainly regarding FCR, that is fludarabine, cyclophosphamide, and rituximab, with fludarabine being answered as the drug of choice if the single best answer is asked. This treatment is only to be given to patients who are relatively younger. They are obviously old people, but relatively younger with no comorbidities. In case there is comorbidity, then we use a monoclonal antibody also, that is called as obinutuzumab. So more, I would say, monoclonal antibodies added to your literature. Additional drugs which are useful for management of this condition are venetoclax and ibrutinib. Now, what is the mechanism of action of venetoclax is that it inhibits BCL2. BCL2, what it does is, by inhibition of this, there is release of pro-apoptotic proteins which cause cell senescence. Cells will die. See, the problem in any cancer is cell is not dying. If I promote apoptosis, by using an anti-BCL2 molecule, then the cells will attain their final senescence and the cells will die. That's my objective. And because it's a B cell tumor, so we'll also go in for a B cell signaling inhibitors like ibrutinib for management of these patients. From the drugs perspective, fludarabine, FCR is primarily to be remembered, along with mechanism of action of venetoclax and ibrutinib, both of which have been asked in the previous exams. When you compare the information that I have said for CLL with CML, you will see stark differences. Now we are having a chromosomal swap here, that is 9:22 translocation, which causes formation of BCR-ABL gene. Now the point is, what is it causing? It is causing stimulation of tyrosine kinase, which will provide unlimited energy to the cells. Because in chronic myeloid leukemia, there is no maturational arrest. In acute leukemias, there is maturational arrest, so single cell will multiply again and again and again. In chronic myeloid leukemia, there is no maturational arrest, so it is all the precursor cells like myelocytes, metamyelocytes, promyelocytes, all will be proliferating in increased amounts and would come into the bloodstream of the patient. So every time you read about CML, you will always read a term shift to left. What the pathologist means by shift to left is that there is no maturational arrest and all the precursor cells are multiplying in excess, and therefore in these patients the TLC values can increase dramatically, especially during the blast crisis component. Initial complaints of these patients would be an involuntary weight loss. The magnitude of involuntary weight loss would be approximately 5 months over a duration of 6 months. Yes, guys, don't answer 10%. In Harrison for IVL, involuntary weight loss, IWL, involuntary weight loss, it is 5% decrease in weight over 6 months. When will you answer 10% is with category B symptoms. In Hodgkin's lymphoma, non-Hodgkin's CLL, in category B symptoms, the weight loss cutoff is 10%. But if category B word is not given, then if for involuntary weight loss, it is 5% decrease over 6 months. And initial symptoms of these patients would be weight loss and excessive sweating. It's a hypercatabolic state. That hypercatabolic state explains the diaphoresis of the patient. In this condition, the scantiest cell in the blood, normally basophil count is about 0 to 1%. If you do a DLC, the basophil count normally is only 0 to 1%. This condition always has basophilia. Basophils will be releasing a large amount of histamine, and when you have is a large amount of histamine coming up, that will explain the pruritus and especially the flushing component which is present in this patient. Traditionally, you read flushing with the carcinoid tumor, but today I'm talking about flushing even with chronic myeloid leukemia because of basophils causing excessive release of histamine. The next manifestation that occurs in these patients is because of massive splenomegaly. Let me just draw a line diagram here to explain this better. Let us assume this is the umbilicus of the patient, left and right hypochondrium. So the spleen in these patients will increase in size and might be even reaching up to the right lower quadrant. The spleen of this patient is so big that it is reaching on the opposite side of the abdomen, starting from the left, going on to right in the right lower quadrant. Massive splenomegaly, so it will press on the colon, it will press on the stomach. So because this massive spleen will press on the stomach of the patient, the pressure on the stomach will cause early satiety. Like this patient used to eat 2 chapatis in a day, let me say 2 chapatis, old person, no, two to three chapatis at lunchtime. Now he says, sir, even after one I feel full. And he's also turning pale. So I thought maybe old man is eating less, so that is why he's turning pale. He also says I'm having constipation. That's because of the pressure on the transverse colon. So when I am seeing this patient early, I might say that old people keep on having these complaints, no, early satiety, constipation, so neglected. But he was very insistent, no sir, it is dramatically increased. Earlier I was a healthy eater. I used to eat 4 chapatis or 3 chapatis, whatever. Now I don't feel like eating and I'm always constipated. So I put my hand on the tummy and I was shocked because there was a massive splenomegaly, which is a very good point to pick up the diagnosis. Now, because in this condition, the TLC part would be increased, so there can be hyperviscosity of the blood. The thrombotic events that I'm describing before you are again very specific for this condition. We can be having is a development of leukostasis. The term I'm using is leuko, that means TLC is increased and there is a poor circulation, sluggish circulation. So the poor circulation in the genitals can cause priapism or a painful erection. The thrombotic episode due to stasis can contribute to MI. Then even respiratory distress can be seen in these patients, cerebrovascular accidents and blindness could be occurring in these patients as well.
You will also read about thrombotic events in these patients because the platelet count is increased initially. Later on, platelet count is lesser, but initially platelet count is more. So thrombotic events in these patients can cause a painful priapism. They could be MI, they could be stroke occurring in a patient, and even a development of blindness. In the later part of the disease, the platelet count will decrease. Platelet count decreases when there's a blast crisis occurring in these patients. You will also notice a very peculiar term. Neutrophil alkaline phosphatase score is less. Now, why is it that the neutrophil alkaline phosphatase score is less in these patients? Is because the neutrophils usually die by 6 hours. But in chronic myeloid leukemia, because of this abnormal gene and the abnormal chromosome, the neutrophils do not die at the usual time. They live beyond their date of expiry. So these post expiry date neutrophils which are still surviving are now having a decreased capacity to kill. NAP score basically is used to test for the killing power of the neutrophils. These neutrophils are past their expiry date, their ability to kill will be lesser, which explains the fact that why in these patients infections will also be present, like recurrent pneumonia could be described. I did not talk about recurrent infections in these patients because that's a standard presentation with all cancers. But specifically for CML, I mean, why do we read NAP score is less is because in this condition, the neutrophils do not die at the usual time. There's an inhibition of apoptosis. The programmed cell death is not occurring. So we are having post their expiry date period neutrophils surviving with less killing power. The granules in the neutrophils which help in killing have been exhausted, have been consumed. So therefore, infections could also be described in these patients. Now let's look at the workup of these patients, and they've given an image, and you could see two colors coming up because there's a genetic reassortment occurring. BCR ABLS had a 9 to 22 translocation, that is long over 9, long over 22 getting involved. So the two colors which are present here are representing the chromosomal reassortment that occurs in this patient, and this is for the best test for diagnosis of this condition, that is FISH, fluorescent in situ hybridization. Most of the MCQs will give you clear hints like basophilia. That's a good pickup point. Shift to left, which means myelocytes, metamyelocytes, promyelocytes present. And in the recently concluded June 22 exam, while I'm recording this recently, the June paper happened. They had given a question where the shift to left and all these cells were described in the peripheral smear of the patient, and the diagnosis was chronic myeloid leukemia. There was no massive splenomegaly given in the question. So a lot of guys said, sir, how can it be CML? The point is, it's not about organomegaly. It's not about organomegaly. It is about these immature cells present in the circulation. Another hint would be low NAP scores, and vitamin B12 is elevated. Shocking, no. B12 should be lesser because in any blood cancer, there is more turnover of DNA. More DNA turnover should cause consumption of B12. So logically speaking, in CML, when there is an increased cell turnover, B12 should be less, but it is elevated. Why? Because the majority of vitamin B12, you see, where is vitamin B12 stored in the body? Liver and white blood cells. Store of B12 in the body is in the liver and in the white blood cells, and in CML, these immature cells are having a higher transcobalamin receptors. These immature cells are having a higher transcobalamin receptor, so they bind to more of B12. And when you're gonna take a blood sample for workup, because the sample will be having white blood cells also, the cells are expressing higher amount of transcobalamin receptor. So the sample will be having, whatever sample you take in the patient will be having higher amount of vitamin B12. This is immature cells expressing more transcobalamin receptors binding to vitamin B12. Bone marrow aspiration of this patient will be showing a hypercellular marrow. The normal myeloid to erythroid ratio is 3 is to 1, 2 to 3 is to 1. Here it's going to be shocking 15 is to 20 is to 1. Along with that, he will also talk about reticulin fibrosis. Additional MCQ which I wanted to remember is Snook silver stain is useful for demonstrating the reticulin fibrosis component. But in bone marrow aspiration, there is no cutoff. I mean, like in acute leukemia, we say na, more than 20% blast cells. But here I'm not saying more than this much percentage is chronic myeloid leukemia. AML is myeloblast more than 20% in the bone marrow. ALL is lymphoblast more than 20% in the bone marrow. But here I'm not saying a percentage. Bone marrow aspiration was done, but to confirm, we can straight away evaluate the chromosomal reassortment, the genetic reassortment that is occurring, and we can go in for FISH, and we can quantify how much Philadelphia chromosome positive cells are present because I want to kill them.
I can also do a PCR for this gene. Well, why PCR is not the answer is because Harrison has written that PCR can be both false positive, high amount of false positives and false negatives for BCR ABL can be present. So if PCR and fish both is given, first answer would be given as fish. Our objective is not only to get a cytogenetic response. My objective is not only to get a clinical remission in the patient, but I want a molecular remission. Molecular remission means that I need a 3-log reduction. 3-log reduction means that technically, mathematically, 99.9% of the cancer cells are killed. When I say molecular remission, it means 99.9% of the cancer cells are killed, and the only ones remaining are less than 0.1% of BCL ABL transcripts. We might read about words like major molecular remission or molecular remission. I mean, molecular remission is the ultimate objective. I want to kill all those cancer cells which are having Philadelphia chromosome and the BCR ABL transcript. Now, the drugs which I have at my disposal are imatinib. Then I have second generation molecules which you can remember as DNB, that is dasatinib, nilotinib, and bosutinib. For bosutinib, one of the important MCQs which was asked in the FMG exam said imatinib resistant CML. When this question came first time, no, I had a guy who messaged me. He said, sir, I did not even remember. I mean, he was under so much of stress. He said, sir, I did not even recall imatinib is the drug of choice for CML. Forget about, he asked in the exam resistant. So I told him, okay, no problems. He did clear subsequently with very good marks. But this is what pressure does to you, that you don't even remember the common drugs which are used for common conditions sometimes. The point is, imatinib resistant CML, it is bosutinib which should be used. And nowadays we are having, I mean, we have another question that is being asked nowadays. I would say the HEP question for CML is that we are having CML which is resistant to both first generation and second generation TKIs. This is because of a special mutation, and this mutation is called as T315I mutation. The T315I mutation is where you would be using two tyrosine kinase inhibitors, two generations of it, they're not working, then the answer is ponatinib. Remember, bosutinib for CML, which is going to be resistant to only imatinib. But if you're going to have two TKI failure, two drugs being used and there's a failure, then due to this name of this mutation is also equally important for the exam, T315I mutation, then ponatinib would be used. In contrast, acute leukemia is relatively easier to understand and comprehend. Acute leukemias will always be having a stormy onset. When you read about ALL, it will mostly be a child. AML will usually be a man more than 65 years of age. Standard features will be the person will turn pale. He might say that, sir, I was a marathon runner, 65 years of age, retired chap from the army. He says, I used to run 5 kilometers daily, sir. But for past 2 months, I don't know, I am turned totally pale, totally white, anemia. There could be petechiae and organomegaly developing. And special findings which are always given in AML are either there could be terms like granulocytic sarcoma. Earlier, we used to read a term chloroma, 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 but now he's replaced the word chloroma by, okay, let me just write it, I'll erase it then subsequently. In older MCQs, you will read the term chloroma. But now, instead of using chloroma, he's saying granulocytic sarcoma. This is going to cause either proptosis. Imagine the cancer cells are multiplying so fast in the body that they're running out of space. So where are they going? They're going to go to liver, causing hepatomegaly, go to spleen, splenomegaly, go to lymph nodes, lymphadenopathy. Due to lack of space, now they'll go to gingiva, they'll get deposited in the eye, extraocular tissue, and therefore you can have a proptosis. This granulocytic sarcoma can even press on the nerves which are originating from the spinal cord. So you could be having a paraplegia. Surprising manifestations. Gingival hyperplasia. I mean, very classical, and you anyway know this question, that the gingival involvement that is seen in these patients, it's a bit of a, I would say, controversial kind of a question, that gingival hyperplasia would be commonly seen with which variety of acute myeloid leukemia. Then in Robbins it is given M4, and in medicine books it is given as M5 variety of acute myeloid leukemia, that would be acute monocytic leukemia. The controversies do happen sometimes, I mean, don't get bothered by them. Then you also have high incidence of DIC with T15:17 translocation. Nowadays, this DIC incidence is reduced with the use of ATRA. When we use all trans-retinoic acid, the chances are relatively lesser. But then granulocytic sarcoma, gingival involvement, DIC, they are very characteristic terminologies which would be present in any patient who would be having anemia, bleeding, and organomegaly. Similarly, with respect to child having anemia petechiae, you might either read the term sternal tenderness. The child was, you were doing a physical examination, you put your hand on the leg of the child, and the child howled in pain. Mother is saying, sir, if I touch the legs of the child, he howls in pain, bone pain. And then sternal tenderness can be elicited. And apart from this tumor can cross the blood-brain barrier. The tumor can cross the blood-testis barrier. Surprising, no? The cancer cells are crossing the blood-brain barrier. They're crossing the blood-testis barrier. So testicular lump, you read about testicular cancer going to other part of the body. But here I'm teaching a blood cancer that goes to the testes. So these special findings would be clinical hints that would help you identify whether it is AML or ALL apart from the age group. And anyway, I need to go in for a flow cytometry subsequently to differentiate. The pathologist will not only go in for morphological features of lymphoblast versus myeloblast. Like myeloblast will be having wire rods. I'll show you wire rods also. But the point is, apart from the morphology of lymphoblast versus morphology of myeloblast, flow cytometry would also aid in diagnosis. Then there are certain chromosomes which are very important and are asked in the topic of acute myeloid leukemia. That should be remembered. 15 to 17, 821, inversion of chromosome 16, and then T16 to 16 translocation. Now, why these numbers are important? You see, if I have to diagnose acute myeloid leukemia in a patient, I will have to do a bone marrow aspiration. And in bone marrow aspiration, I will have to demonstrate that, okay, the concentration or the value of myeloblasts on bone marrow aspiration will be given to be more than 20%. But you will notice that there will be lot of clinical situations and MCQs where he will mention myeloblast are only 15% and he is still answering AML. Myeloblast are given to be 10% and still is answering AML. How is it, if the cutoff is 20% or more, how is he answering even in the absence of cutoff not being breached? It is because he will tell you that the chromosomal analysis of this patient, that is the fish of these patients, revealed these chromosomal swaps present. So this is a special marking in the table in Harrison. Is mentioned that traditionally we'll do a bone marrow aspiration. In this bone marrow aspiration, the pathologist will first do morphology, then he will do flow cytometry and will be able to tell us, okay, it is a myeloblast. But in patients who are having these chromosomal swaps, you do not need a cutoff. Even if the blasts are less than 20%, even if the MCQ is saying 15%, but if the chromosomal swaps are present along with these obviously clinical findings given, you will say this would be acute myeloid leukemia in a patient. The investigational choice for acute leukemia is always a bone marrow aspiration, and the sample will be sent to the pathologist, who would then be putting up special stains. They'll put up flow cytometry and they'll obviously examine it under a microscope to say it's a lymphoblast versus a myeloblast. Now, the image of myeloblast is characteristic with respect to a bigger nucleus and then presence of these eosinophilic rod-like structures which are called as Oyer rods. The highest concentration of Oyer rods are found in M2 variety of acute myeloid leukemia. For performance of bone marrow aspiration, I can be using a Sala's needle. In Sala's needle, as you can see, there's a side screw, S for Sala's needle and S for side screw present, and then there's a Klima's needle in which a guard is present. So for bone marrow aspiration, we could be using any of these two needles here. And then I've also used this opportunity to mention regarding bone marrow biopsy. Bone marrow biopsy is what we usually do in patients of, let me say, myelofibrosis, where bone marrow aspiration might be having a dry tap. Or bone marrow biopsy will be also useful for diagnosis of multiple myeloma. One of the there could be multiple contraindications for doing this procedure, but thrombocytopenia is anyway, this is itself a question. Low, like normally, no, why we don't do a lumbar puncture if platelet count is low. We don't do a lumbar puncture if platelet count is low, but thrombocytopenia is not a contraindication for bone marrow biopsy. Why that is so is because sometimes the cause of thrombocytopenia could be picked up only with the help of bone, because we want to make a diagnosis. Why is it happening? So we'll take the risk. So bone marrow biopsy needle, the T-handle bone marrow biopsy needle has just been shown for completion of the discussion. Otherwise, primarily for diagnosis, I'll do a bone marrow aspiration, send it for morphology and flow cytometry, and the pathologist would be able to then give you the final report. Once the final report comes up, for AML, the drugs which are used are cytarabine and daunorubicin. But for M3 variety, that is acute promyelocytic leukemia, we will have to use ATRA. And how does ATRA work? It's a vitamin A derivative. No, it works by causing differentiation of cells. See, in acute myeloid leukemia, there is a maturational arrest. In chronic myeloid leukemia, there was no maturational arrest occurring. There was only a clonal proliferation. There was myeloproliferation occurring. But here there's a maturational arrest. So what I am doing is differentiation. And once the cells will differentiate, then they will die also one day. I mean, if there's a maturational arrest, the cells keep on multiplying again and again and again. They live for longer duration. But once you achieve normal maturation, every cell has a destined life due to telomerase activity, and therefore they would be senescence of these new plastic cells. But when they die, there is a side effect also. The side effect is that these cells, when they're dying, they stick to the pulmonary endothelium and cause a ventilation perfusion imbalance. And because of this ventilation perfusion imbalance, which is caused due to damage to the microcirculation of the lung, the patient after given ATRA will start having respiratory distress. On one hand, I am praising ATRA as a very effective step for management of acute promyelocytic leukemia. On the other hand, I'm telling you, patient is having respiratory distress. This is primarily happening because this is damage to the microcirculation of the lung and is called as differentiation syndrome. Because we know that after administration of ATRA, there is going to be distress. You will have to give steroids to the patient. There was a question in INICET/AIMS which said that a known case of APML was given ATRA and there's a respiratory distress. What could be the reason? Options given were like, one was that the patient is having an opportunistic infection. He developed a pneumonia. Another thing was that this particular chap, he is having a developmental differentiation syndrome. So your answer would be what I've just explained, and we can actually manage it with usage of steroids. There's no need for giving antibiotics for these patients, and the respiratory distress would gradually ease off. At this time, I also want to talk about leukostasis. Leukostasis is more common with acute leukemias. Whenever you read leukostasis, that would mean the TLC of the patient will go up to as much as 1 lakh. All the four important blood cancers are the ones which are to be studied from the hematological perspective. And lastly, I'm showing some slides before you which have been asked in the exam. So the first one, all of these are X-ray skulls. I think the first two are easily picked up by you guys. You can see the raindrop configuration and lytic lesions which are present here in the skull. So he's talking about in this particular question with respect to multiple myeloma. For diagnosis of multiple myeloma, the count, the plasma cells in the bone marrow should be more than 10%. In pathology, you will also read a cutoff of 60%. That 60% is if clinical features like CRAB, like hypercalcemia, renal failure, anemia, and bleeding is not given, which is called as myeloma defining events. So the cutoff is 10% in the presence of the triad that I'm talking about. That is, you would be able to demonstrate the M component in the plasma. You see, when you do a serum electrophoresis of these patients, the serum electrophoresis will be showing an increase in the gamma globulin component. This is how the recording will be, and you will see a big spike which would be called as a church spire appearance. That's the M component, and it can be quantified also when more than this much per deciliter or more than liter. And the third thing that you will encounter in these patients of multiple myeloma, apart from plasma cells and M component, would be myeloma defining events, which could be remembered with a mnemonic CRAB, where you would be having is hypercalcemia. That's because of the lytic lesions that are occurring, but the serum alkaline phosphatase in these patients is not elevated. It is always normal. Then would be renal failure. The renal failure can be explained by the fact that in these patients, there is Bence-Jones proteins which will block the tubules. You know, the light chains of antibodies are getting excreted in large amounts in the urine. They block the tubules. And hypercalcemia will also damage the kidney. So there are two reasons why kidney is damaged. One is that the tubules are getting, there's a clogging of the tubules by Bence-Jones proteins, that is incomplete light chains. And hypercalcemia component also contributes to it. Then another feature that would be encountered in these patients is anemia, and then would be bony lytic lesions, and even bleeding can be present in these patients also, because the plasma cells will take up all the space in the bone marrow. So megakaryocytes will not be having space to grow, and therefore thrombocytopenia can explain the petechiae, purpura, and the bleeds in these patients. In contrast, in the second image, which is for thalassemia, you can see the characteristic hair on end appearance. This hair on end appearance is what you're going to see with the hemoglobinopathy, that is going to be thalassemia. If he says what is the best way for diagnosis of thalassemia, most of the time in India it's beta thalassemia that would be asked to you. So one is that you can go in for beta globin gene estimation. You can go in for a PCR and evaluate beta globin gene. If beta globin gene estimation is not available in the MCQ, then your next answer would be given as HPLC, that is high performance liquid chromatography. And the third one would be electrophoresis, but first try to answer it in the sequence that I mentioned. For beta thalassemia, packed RBCs would be given for survival, but the treatment of choice for beta thalassemia should be answered as allogenic stem cell transplantation. If he says what is the earliest radiological finding in beta thalassemia, then don't answer here on end. Do not answer here on end. If he says earliest radiological feature that develops in these patients, then there is a extramedullary hematopoiesis occurring in these patients. The earliest radiological finding that develops in thalassemia patients would be answered by you as squaring of the metacarpals. You know, metacarpal bones in the hands would look like dumbbell. So in this patient, because there is a extramedullary hematopoiesis and there is a expansion of the bone marrow, the expansion of the bone marrow will explain the change in the shape of the metacarpal. A very classical term that you read is squaring of the metacarpals is one of the early radiological finding that would be encountered in patients with thalassemia, and subsequently, I mean, that hair and end appearance would be present. And another feature that is also useful for diagnosis of this patient, but I'm not writing, is chipmunk facies. Chipmunk faces would mean that the cheeks of the patient will be very prominent because there's a bone marrow expansion. So maxilla becomes very prominent in these patients. They would be upturned nostril, like in you and me, nostrils are placed downwards. No, the nostrils will be placed a little anteriorly, and the upper lip will also be prominent in these patients. So you will read this term lots of time, chipmunk faces, in patients of thalassemia. Along with this, there would be anemia present and a splenomegaly. You do not have a splenomegaly in sickle cell anemia, obviously, because of the autosplenectomy component. But if you have a kid with progressive anemia, splenomegaly, chipmunk faces, you have to think in terms of thalassemia major. If the age of the child is less than 1 year, after 1 year, it's going to be thalassemia intermedia, and thalassemia trait does not have clinical presentation. Thalassemia trait would be silent. If you look at the third image, when it came in the exam, a lot of guys initially thought that because it's X-ray skull, so they casually marked it as multiple myeloma. But look at the lesions here. No, I mean, if I just try to show the big amount of lesion present here, they are relatively much more bigger circumscribed lesions. And you can also notice that the skull of this patient is looking more hyperdense. So this particular X-ray that are shown here before you is for a patient of Paget's disease. You will say that, sir, in Paget's disease, we have read about cotton wool skull. So, okay, I mean, that manifestation is currently not present, but there is I would say, a bone which looks relatively more hyperdense, and lytic lesions can be present. Lytic lesions can be present even in cases of Paget's disease, in which you will be having a disproportionate rise in the value of serum alkaline phosphatase. In multiple myeloma, SAP is always normal. Multiple myeloma, SAP is always normal, but a disproportionate rise of SAP is seen in patients of Paget's disease, where there would be a deformity of the skull also developing, and then even hearing deficits could be developing in an old person. Even heart failure features could be present in Paget's disease. I said skull deformity, sensory neural deafness developing, and even anemia developing in these patients, and even heart failure developing in these patients subsequently. So not every X-ray skull that is given to you would be with respect to that of multiple myeloma. The one that I'm saying next verbally, and I'm not writing it down, is geographical skull, where they would be like, the lesions in the skull would be looking like map of a country. And that is when you read that in pediatrics, geographical skull is seen with patients who are having a very characteristic term that I'll use, Schuller-Christian disease. That would be also called as, a version of it is also called as histiocytosis X. So I mean, I will focus mainly on the internal medicine part component. So I said the pediatric part verbally, but you can go through that in the pediatric segment as well. So these are the details that I would like you to remember, guys. I mean, keep the pressure on, keep hammering, as I say always, and you will break on to the other side. Keep the faith in your capabilities. I know you're tired. I know that you get frustrated when the scores in the GTs become lesser, but it's all about persistence. It's just a matter of short few months, and then it's going to be glory. And don't say that we've been listening of this consolation for a very long time. I know that, right? Since you were in class 10th, your mama used to tell you that beta thoda sa pad lo and things would be cool. I know that, right? And we all go through that. All doctors go through that stage, that we study in class 10th, we are toppers in our school, we class 12th, and then boom, in medical college, we are surrounded by all toppers. And when you're surrounded by all toppers, you start doubting yourself. Am I really, really good? But you are good, guys. You are the cream of the society. Why have you become a doctor? Is not by chance. It is because you were destined to be one. And saving somebody's life is not a joke. Saving somebody's life takes a part of you. So you sacrificing some of minimal joy, which going to a mall, going to a movie, it's important. Agreed, it's important. You should go to a mall. You should go and enjoy your life, right? But at the same time, you are sacrificing some of those things which these ordinary people are doing because you are the best one, right, that we have for the future of our country. So keep the pressure on, and I'm very sure you will break on to the other side and come up with brilliant ranks.